Yeah, you are online.
A very good evening and welcome to this webinar of Chandigarh Ophthalmological Society, Oculofacial Aesthetics for Ophthalmologists. It's an exciting webinar. It's something different from what we've done earlier, and I think what is seen normally. We have an esteemed panel from all over the country, both ophthalmologists as well as plastic surgeons. And I think we're really going to gain a lot out of it. I will not take too much time. First, I'll ask our president of Chandigarh Ophthalmological Society, Dr. Jaspreet, to say a few words, and then we will start with the rest of the proceedings. Dr. Jaspreet, please.
Very good evening to all of you. And thank you, Dr. Chintan, for coordinating and organizing this on the Chandigarh Ophthalmology Society platform. Indeed, I mean, since the lockdown, you've been quite active, and actually, it's been going on almost every month. We never missed a webinar, and we were just waiting for this oculoplasty webinar. It's been, I mean, a long time since we had this webinar, and yes. All this has been because of the efforts of Dr. Usha Singh, whom I used to meet daily and tell her, ma'am, you're just working too hard. I mean, the effort she's put in, the way it's been designed, it's absolutely fantastic. I mean, I'm really amazed. I said, ma'am, I won't be able to do such a thing what you've done. I mean, the way it's prepared. And you have such an impressive faculty here. I mean, it's something very wonderful. I mean, and hope that this webinar is great for the audience. They learn a lot from it. And without taking much time, I wish you all the best and have a great discussion. And of course, be super spreaders of the aesthetic knowledge. Thank you so much.
Thank you, Dr. Jaspreet. We'll now just start. I will start. I'll introduce Professor Usha Singh, who is, as Dr. Jaspreet said, the one who's responsible for really this webinar happening the way it is. And so we'll just go on. We are starting now. Yeah. Before we start the webinar, thanks to our past members of the COS, the senior members who guided us all along and are still guiding us, and also our present executive who are always there to help us whenever we need anything. Professor Usha Singh, like I said, she's been the driving force behind this webinar. She's currently working as Professor of Ophthalmology at PGI Chandigarh. Her areas of specialization are oculoplasty and retinoblastoma, and she has significant publications in the above areas. She has also been the ex-president of the Chandigarh Ophthalmological Society, and she has been the past executive member of the All India Ophthalmological Society, the North Zone Ophthalmological Society, and life member of the International Society of Ocular Oncologists. She is the recipient of the Best International Scientific Award in Retinoblastoma at the International Society of Ocular Oncology, and also received the Best of Best Poster Awards at the European Society of Ophthalmology. And in 2019, Professor Usha Singh was honored with the Best Woman Doctor of Chandigarh by the Bharat Vikas Parishad. So that's an impressive CV, and I will now hand over the proceedings to ma'am, Professor Usha, to introduce the rest of our panelists and our speakers, and really looking forward to this webinar now.
Thank you, Dr. Chintan, for this wonderful words. So at the outset, I would like to thank the President COS, Dr. Jaspreet Sukhija, for giving his encouraging words and also giving us this opportunity to conduct this unique monthly meeting and on a specialty which has not been covered before in the COS meeting, and that is subspecialty of ophthalmology. And we are having the topic of aesthetics and ophthalmology, and this is for the first time that such a topic is being discussed in COS meeting. And I hope that in future we will continue to have some of these sessions. Now I would like to welcome all my guest speakers, Dr. Kasturi Bhattacharjee, Dr. Devraj Shom, Dr. Vinay Keshamurthy, and Dr. Feroz Manjandavida, and all senior COS members, all participants and audience. And at this moment, I would like to welcome my co-chairperson, Dr. Kasturi Bhattacharjee, and moderator, Dr. Debraj Shom, to the digital dais. And I will request Dr. Debraj to take over the um, to take over the proceedings of this conduct of the session. Dr. Debraj.
Thank you so much, madam. Thank you for having me here, everyone. Thank you from the COS, all the office bearers of the COS and Dr. Usha for having me here. It's a matter of great pride and privilege to invite my panelists of this particular oculofacial aesthetics meet. Dr. Raman Mittal, who's been my senior from LV Prasad Eye Institute, as well as a very well-known oculoplastic surgeon from the Punjab and Haryana area, is a panelist. Dr. Vinay Keshavamurthy, who comes in from an allied specialty. Dr. Vinay, it'll be nice to have your video on as well. Dr. Feroz, who's a great friend of mine and who's part of, started this wonderful organization called Horus in Bangalore for the last 5 years. And Dr. Manpreet Singh, who's a very close friend of mine and is a very quickly upcoming oculoplastic surgeon from the northern part of India. So I would request them to join the dais. And now I request Dr. Usha to please introduce the keynote speaker for today's meeting, which is Dr. Kasturi. I doubt Dr. Kasturi needs any introduction, but nonetheless, we should complete the honors.
This one now. Is it being shared?
Yes.
Okay. So I will go to the, for today's session, we have, pardon? Hey, just a minute. So for today's session, we have a lot of speakers, and our speakers are Dr. Kasturi, Dr. Debraj, Dr. Keshav, Dr. Feroz. And now I would like to introduce our keynote speaker, Dr. Kasturi Bhattacharjee. And Dr. Kasturi, she is currently the director of Sri Shankar Deva Netralaya, Guwahati, and she's the recipient of more than 30 prestigious awards for her work in ophthalmology, and that's very impressive. And she has trained more than 80 fellows and is the thesis guide and examiner for Diplomat of National Board and subject expert for PhD thesis. She's a reviewer for many national and international journals. She's a global examiner for FRCS Glasgow for last 15 years, and she's involved as an investigator in many intramural and extramural researches. She's also the past vice president of AP Soppers and past secretary of OPAI. So I welcome Dr. Kasturi, and I would request her to deliver her keynote talk. Dr.
Thank
Kasturi.
you, Dr. Usha. Yeah. Let me open this. 1 minute.
Oh, no.
By the time Dr. Kasturi comes in with her presentation, I would just like to add on, she is one of the most aesthetic face that we have in our whole oculoplastic society, I think, and she is the right person, Dr. Kasturi ma'am, who's been chosen by Dr. Usha Singh to be as a keynote speaker here. Welcome, Dr. Kasturi.
Can you see my slides? Is it okay?
Ma'am, can you just stop and again share?
Good. Let me see. Can you say something? Can you see my slides now?
No, we cannot see your slide.
Can I interrupt for a minute?
Yes,
Dr.
please.
Debraj?
Yes, ma'am.
I think I'll give my anatomy talk, and then Dr. Kasturi will be giving her.
So sure, ma'am. So it gives me great pleasure to invite Dr. Usha Singh. I don't think Dr. Usha Singh really needs any introduction as such. And right from the time that all of us have ever thought of oculoplasty, she's been one of the folks that we've always looked forwards to. She completed her MBBS in 1985 from JIPMER Pondicherry, and then completed her MS in ophthalmology from 1991 from PGI Chandigarh. And then under the guidance of Dr. Amod Gupta, she went ahead and set up the first retinoblastoma clinic in northern India. So I don't think there's anything that needs to be said about ma'am as such. And she's also the patron at this moment of this particular oculofacial aesthetics meet that we are having. So I welcome Dr. Usha Singh and request her to please give her talk first.
Thank you, Dr. Devraj. I'll start. Anatomy would be useful. Before we go on to the details of the aesthetics, sorry, Dr. Kasturi, I think this got skipped somehow. How do I full slide? This one?
Yes, ma'am.
Okay, so good evening, everybody, and I'll be talking about the facial anatomy for aesthetics. So it's important to know the anatomy, and the upper 1/3 and the middle 1/3 of the face concerns the ophthalmologist, and so we ought to be knowing all this in detail. So so it's essential to have knowledge of the anatomy of the face and its relations to prevent complications and to get the desired results. And the definitive goal of surgical correction is preservation of function and appearance, and that in turn is dependent upon the deep understanding of the complex structural and functional anatomy. For using neurotoxins, we need to have the three-dimensional anatomy, and for fillers, we need to know the fat compartment anatomy. So the muscles of the facial expression, they insert onto the undersurface of the dermis via fibrous septae, and muscles of the face, they have significant impact on the facial aesthetics. Muscles of mastication, they influence the shape and proportions of face, and repeated contraction of the muscles of facial expression, they result in dynamic and static rhytids. And these rhytids, they give a aged look to the person. And therefore, then comes the need for rejuvenation to restore the youthful appearance. Now, what are rhytids? Rhytids are seen in aged face, and a sagging face, as we know, it's not just a simple act of gravity, but much more complicated interaction of fat atrophy, bone resorption, dynamic musculature, and changes in collagen and elastin. And the definition of wrinkles have been given by Lemperle in 2001, and this is widely accepted. The superficial wrinkle, it is called aging and photoaging, and it's limited to the superficial dermal creasing. And mimetic wrinkle is caused by repeated facial movement, and it is limited to the superficial partial thickness of the deep dermis. And a furrow would be involving the deep dermis, but the entire full thickness is involved. And a fold is an overlapping skin, and this is caused by genetic laxity, intrinsic aging, loss of tone, bony atrophy, and gravity. Now, there are various procedures have come up for rejuvenation. That is, it could be surgical or non-surgical. We have a lot of procedures which have been described: upper lid blepharoplasty, lower lid, rhytidectomy, localized or entire full face. And then there are neurotoxins. Non-surgical ones are neurotoxins for the rhytids, forehead, and for nasolabial folds and lasers, and facial contouring and enhancement with fillers, as we can see over here. So when the anatomic considerations for non-surgical rejuvenating procedures, we are using neurotoxins and fillers. For neurotoxins, we need to know the location and depth of each muscle of facial expression, the bulk of the muscle and its action, within the muscle, which is a target point, which would give us the best aesthetic appeal. And for fillers, we need to have a complete understanding of the key vascular structures, which is necessary to avoid vascular injury. So we need to know the depth of the arteries and veins, and we need to know the watershed zones and the danger areas which we need to avoid. So though we get very good results with aesthetic, all these procedures, there are disastrous complications which have been reported, and the worst being the blindness. Others are ocular ischemia, skin necrosis, edema, erythema granulomas, and infections. So coming to the facial vascular danger zone areas, there are 6 of them in number. And the first being the glabellar area, the temple, nose, perioral area, infraorbital region, and nasolabial fold. And these are have been marked over here. We can see this is the infraorbital region, this is the nasolabial fold, this is the perioral area, and there's a temple area, and there's a glabellar area. So in the forehead, glabella and brow rhytids, for in this region, there is a watershed zone, and there's a communication with the central retinal artery. The arteries initially they are deep, but they become superficial an inch above the supraorbital margin. And the intravascular filler placement, when it is being used, it could lead to blindness because there's so much of anastomosis and between the vessels. This will be better seen in the next slide. So when we are injecting fillers and all, we need to keep the needle in the intradermal plane. And in the glabellar area, we have this the frontalis muscle is solely responsible for elevation. And for neuromuscular injections, we have to remain 2 centimeters above the orbital rim to prevent ptosis. And in the corrugator, this has a bulk on the medial side. Maximum bulk is on the medial, the head. And as it progresses, spreads out laterally, it becomes more superficial. So the injection should be deep. This red dot tells about the deep injection which has to be given, and the rest are all superficial. And in the frontalis muscle, all they have to be given superficial injections of the neuromodulator injection. Now coming to the temple area, now the anatomy over here, as we can see, this is the frontal branch of the temporal artery which traverses the temporal hollow and within the temporoparietal fascia, and it goes medially, and it anastomoses with the branches of the supratrochlear and the supraorbital branches. And so this is this watershed zone, this side, and over here, this artery could get injured in the temporal area. And when we are using fillers, we need to avoid the supratemporal artery and middle temporal vein. The middle temporal vein drains into the jugular vein. Now, in the superficial temporal artery, when the delivery is being given to and a filler is being put, it could go to both the eyes. That's why we need to inject 2 centimeters above the zygoma, somewhere here, and posteriorly from the tail of the brow. Now, the choice between needle and cannula, needle is better for injections into a subdermal area, and cannula is recommended for avoiding vascular compromise when injecting filler into deep fat layer and releasing fibrotic ligamentous structures. The intraorbital region, the intraorbital foramen is there, and this is 1 inch from the midline and 11 millimeter below the intraorbital margin, and just slightly less than a finger breadth below the intraorbital rim, immediately lateral to the medial limbus. The tip over here is when injecting a filler into the malar fat compartments, we have to stay lateral to the foramen and push the product towards medial canthus. Regarding the nose, we have to remember that nasal vessels are all superficial. So the nose has a robust blood supply by the angular artery, which originates from the alar base and runs in the nasal facial groove, and it communicates with the ophthalmic artery and the central retinal artery via the dorsal nasal artery. And any accidental injection could lead to blindness, skin necrosis, ocular ischemia. And the neurotoxins are used in the nasal area, especially for the bunny lines, rhytids. And here the injection is given into the nasalis by raising a superficial wheal between the nasofacial groove and dorsum of nose. For safe filler injection, we need to stay deep and only in the midline. Because the dorsal and the lateral nasal arteries are superficial. In a patient with multiple nasal surgeries, we have to be extremely cautious or not put fillers at all. The nasolabial fold, as we can see in this patient over here, it is the facial artery is running underneath that, and this facial artery is in the deep portion of the facial artery. It is in the lower 2/3 and it lies beneath the muscle. The superficial 1/3 is near the alley, and it is supplied, and it is the angular artery which supplies after giving off the labial artery and communicates with the dorsal nasal artery, which is a direct branch of the ophthalmic artery. So the important tip over here is the second most common site to give blindness, so we have to be very cautious over here. The tip here is in the inferior 2/3 of the nasolabial fold, where the artery is deep. The filler injection should be given the superficial subcutaneous tissue or in the deep dermal plane, and in the superior 1/3, it has to be deep dermal or in the pre-periosteal zone. Now, coming to the lateral orbicularis oculi rhytids, they are wrinkles which are accentuated by the accordion-like action of the orbicularis oculi muscle during movements of facial expression, as the muscle shortens but the skin does not. And in a study here, they have divided this into unidirectional and bidirectional. In majority of the patient, the bidirectional rhytids are more common, and measuring these rhytids is of no use in above 40 years. It's useful for the 30 to 40 years age group. The treatment is a neurotoxin injection, and this is given below the tail of the brow and proceeding inferiorly to the vertical plane of the lateral canthus. Injection should be subdermal at 45 degrees, and caution is that deeper zone may paralyze the zygomaticus major, weakening the ipsilateral smile. Surgical anatomy of the lower lid. It has been divided for the aesthetic purpose. It has been divided into 3 layers: the anterior, which consists of skin and orbicularis oculi; the middle is orbital septum; posterior layers is by tarsus, tarsal muscle, and capsulopalpal fascia. This fascia fuses with the tarsal muscle. Tarsus about 5 millimeter inferior to the tarsus, and there is the suborbicularis fat, which is just deep and below the orbicularis oculi. We can see it in this this circle highlighting it, and any sagging of this SOOF leads to malar bags, and raising this SOOF has a role in blepharoplasty, and this terminology of SOOF was used by the plastic surgeons who used to routinely excise it to prevent post-operative puckering. And now there are 2 terminologies: tear trough deformity and the nasojugal fold. And are they both the same? So there is an interesting article which is of special use of importance to the aesthetic surgeons. And this has come out in 2018. And as we can see, a groove in the infraorbital region refers to the narrow furrow around the infraorbital rim. Hollowness refers to the infraorbital region, and it refers to the sunken space in the infraorbital area. The tear trough deformity is a superior aspect of the nasojugal groove that occurs in patients from all age groups. The nasojugal groove or the fold, it corresponds to the position of the inferior border of the the orbicularis oculi muscle, located slightly inferior to the tear trough deformity and more obliquely. And then there is the palpebro-malar groove. We can see over here, this is the orbital fat, this is the orbital septum, this is the SOOF, and here's a medial orbital fat and the orbicularis oculi muscle. And this is the preseptal orbicularis, and this is the alegnesi muscle in the extreme medial. And this is the patient's photograph which has been taken from this publication. And this is a middle-aged lady who has come with these folds, and here the tear trough deformity is very prominent. She also has a nasojugal fold, though it is not very prominent. Then she has a medial cheek groove and the palpebromalar groove over here. So facial fat compartments, there are two types, the superficial and the deep. And for the anatomy is very important while injecting fillers in these patients. So the tip over here is to remain, the relevance here is that the volume loss in the deep cheek fat compartments and the resultant ptosis of the superficial fat compartment leads to formation of mid-cheek grooves, deep and nasolabial grooves, exacerbation of facial grooves. While injecting a filler for volume augmentation into the malar fat, we need to stay lateral to the infraorbital foramen. So coming to the conclusions, a detailed knowledge of the facial anatomy allows safe and efficacious injections of neuromodulators and fillers. Injection technique based on the compartment specific volume augmentation has improved the ability to treat the aging of the midface. Thank you.
So that was a wonderful presentation, Usha. So at the outset, can you hear me?
Yes.
Yeah. Let me share my screen. So at the outset, I'd like to thank Dr. Usha for giving this opportunity. And she's like one of my best friend, sister figure to me. And I have got tremendous love, respect, and regards for her. So happy to meet Dr. Manpreet, who is one of my most favorite fellow, Dr. Chintan and Dr. Jaspreet for arranging this wonderful workshop. And it is really wonderful to meet my colleagues, especially Dr. Deb and Dr. Feroz. So I'll be speaking. Can you see my slides now?
Yes.
Is it clear? Okay.
Yes.
I'll be speaking on the oculofacial aesthetic surgery by the ophthalmologist. So the common oculofacial aesthetic surgeries which are performed by the ophthalmologist are basically the blepharoplasties, as Usha had already mentioned, which includes the upper lid blepharoplasty, the lower lid, and the blepharoplasty combos. And also in Asian configuration, we have to do a lots of epicantoplasty. So the word blepharoplasty, basically it comes from the Greek word blepharon, and the plastico means to mold. So blepharoplasty is basically a surgical technique where we need to excise the skin, where we need to excise the muscle and the fat, and these are being redraped and also being sculpted. So this is basically where it deals with all the layers of the tissue. Layer by layer, we need to excise it, and whatever is excess, we need to excise it. And once it is being excised, and we tell the counter excision to be done, and we bring about a change so that the age look reverts back into a much younger look. So when I speak about anatomy, it is very important that each of us should know, sorry, is it okay? Each of us should have a clear understanding of the anatomy of the lids, basically the difference between a Caucasian and the Oriental eyelids. So when I speak about a Caucasian eyelid, this is basically they have a beautiful crease, and you can see the LPS muscle, the aponeurosis twigs gets inserted into the skin, and the pre-aponeural fat is much above the tarsus place. So this is my tarsus. But in case of the Asian, you can see that the tarsus is being shorter, and you can see that much of this fat, this pre-aponeurotic fat, it comes down to the tarsus, and there's hardly any crease that is normally seen in case of a Caucasian eyelid. So the most important, whatever surgery or it's a botulinum toxin injection or a filler, the pre-operative assessment is most important. And the most important aspect that we need to see the size, the shape, the symmetry. The tarsal plates show any associated ptosis or there's hollowness or prolapse or the lateral hooding. When I speak of the size, we all know there are 6 main shapes, and all the shapes are fabulous, I feel, in their own way, whether it's a monolith or it is a hooded one, or it is a downturned one, or the upturn, or it's a beautiful almond-shaped eyes. And the second important is the tilt. If I draw a line from the medial to the lateral canthus and another from the medial caruncle to the lowest part or the highest part of the lateral canthus, usually this should be always above the blue line. So this is what we want, the upward tilt. But many a times in a mongoloid eyes, we see sometimes a downward tilt. So symmetry is very important. Many a times they want us to do a little increase in the crease side. And this is very difficult because you need to have a small crease, and also you want to make a good symmetry between the eyes. Sometimes you see patient like this, where you see they have got a single crease, and you operate on only one side of the eye in order to make a double crease. So this is a little challenging situation, as you can see here. And sometimes this is again an asymmetry that you can see here, where I need to do a blepharoplasty on both the sides in order to make a more symmetrization. Next important measurement is the tarsal plate show and the brow fat span. This is important because when we all know the normal it is approximately this 3 to 4 millimeter. But in situation like this, when there's a ptosis, we see that the TPS and the BFS, the ratio differs. Normally, it should be 1:1.5 medially and 1:3 laterally. So whenever there is any change in the position in the eyebrow or in the eyelid, there is a change in the TPS and the BFS. And like a situation like this, here you can see that she had undergone a surgery only to increase the TPS, as you can see here. So this is the same patient, you can see. The next important that you need to measure the palpable fissure height and the MRD1 in order to rule out ptosis. You need to evaluate if there is any lacrimal gland prolapse, and also the prolapse is involving only the orbital part or both the orbital and the palpebral part. You need to evaluate if there is hollowness, because if like this patient of mine, she has got tremendous hollowness. So in this situation, you cannot excise the fat. You need to retrip the fat in a reverse direction. So the association of the dermatocalasis and the lash ptosis is very important, whether it's a case of epiblepharon or whether it's a case of dermatocalasis, because we see that the lashes keeps on touching the cornea, and Dr. Chintan will agree to me. Because of the constant touch of the eyelashes, you can see it leads to dryness and it leads to development of the SPKs. And this SPKs leads to a vicious cycle. The lashes touching the cornea, irritation, release of the cytokines, inflammation, increased osmolarity, then reduced tear film, and also the vicious cycle keeps on going. So to relieve the symptoms and signs, this blepharoplasty is the surgery of choice, where we redirect the eyelashes so that in order to prevent many of the corneal complications. So as I already mentioned, the blepharoplasty is the procedure having both aesthetic and the functional indication. But traditionally, it's a subtraction form of surgery that involves the excision of variable amount of the muscle, fat, and the skin. But the most important step is the surgical marking, and we usually follow the rule of 10. That is, from the eyelash to the lower part of the mark, it should be 10 millimeter. The upper part of the marking to the eyebrow should be 10 millimeter, laterally 10 millimeter. But in a very aged lady, and when you have some amount of dermatochalasis, you can have this marking as less as 8 millimeter, but not beyond 8 millimeter. So the technique can be a simple outdoor procedure, which is a suture technique, where you can give a single suture or a multiple suture to form a beautiful lid crease. And this lid crease you can see, but which forms so beautifully within few minutes, but these are not very prominent. So in order to make a very prominent lid crease, we usually do the surgery, where the first step is a nice marking. You need to assess how much amount of tissue that needs to be excised. Is the video clear to you all? Hello?
Yes, it is quite clear,
Yes,
Dr. Kasturi.
yes, ma'am.
Yeah, thank you, Raman. So you need to excise the skin, and following the excision of the skin, the next important is the excision of the orbicularis. So this part, the pre-septal part of the orbicularis needs to be excised, not the pre-tarsal, otherwise you'll have a leg ophthalmos. And we all know the lid skin, it thickens from the eyelash towards the eyebrow. So the more higher we go, the lid also thickens more. So the next step, and you need to measure how much amount of orbicularis you have excised, because it might lead to leg ophthalmos if you excess too much of orbicularis. So once you remove the skin, the orbicularis, next you need to expose the orbital septum. You incise the orbital septum and you expose the two fat bed. We all know, Usha has mentioned it very beautifully, that upper lid, basically we have the two fat bed, the nasal, which is little white in color, and the central. So you need to excise depending upon the type of the lid configuration, whether it's an Asian lid or a Caucasian. In Caucasian, we usually do not remove the central part of the central fat bed. Like you need to remove only the lateral part of the central fat bed and the medial. When in Caucasian, we usually do not remove the central part, that is the medial part of central fat bed. So once you remove the fat bed, especially this is the Asian lid, so you need to make the lid crease formation suture, which includes the skin, orbicularis, tarsus, LPS, back orbicularis skin. So this way you need to give 5 incision, and once you finish this giving the incision, you put the skin suture, which is usually a monofilament, either a 7O or a 6O proline. But the end point is, you can see this is the eversion of the eyelashes. So this side is the operator and the right side unoperator. You can see the eyelashes are still straight. So you have to little eversion of the eyelashes. So besides giving a good TPS, you also treat the lash ptosis, which is very frequently seen in situation like this monolid. This lady, she comes with a monolid and you do a blepharoplasty surgery. But the most important that the dynamics and also the symmetry in the different views, as you can see in the 2 lateral views and the gaze. So even when they look in the different gaze, the symmetry should be maintained. And it should be permanent. Like this lady of mine, she comes back to me after 14 years, and you can see it's so beautiful lid crease, and also the brow has also been lifted so well. The next important, what I need to mention is that you need to maintain the ethnicity. Like many of these young girls, they want to maintain the Asian ethnicity. They don't want very big TPS or the very big lid crease. So this is a little challenging. I feel it is more challenging to have a smaller lid crease than to have a bigger lid crease. Then the blepharoplasty combos, this is the main 4 indications of the blepharoplasty combos, which can be a lacrimal gland prolapse, the ptosis, the brow or the eyebrow ptosis, and the apicanthal fold. Like this girl, she comes to me with a lacrimal gland prolapse, and she had a gross amount of blepharochalasis, and this is a CT scan where you can see the lacrimal gland on both the sides are very much prominent. So this is a very clear-cut example of a blepharoplasty combo, where first you do the steps of blepharoplasty that I have already shown, excision of the skin, but not the orbicularis, because she has a blepharochalasis, and this is a beautiful lacrimal gland here. And this gland, you need to expose it very well. And once this
exposed, you need to, once it is being exposed, you need to separate it from the rest of the fat. And then I usually, initially in my early days, I used to take proline, but now what I prefer, I used to prefer Polydex, that is the polyester, because it does not cut through this periosteum. So you need to push the gland down deep into the orbit to see whether it can be replaced, and then you need to give 3 matrix suture in the capsule and the surrounding tissue, and then down, which and up to the periosteum. So this is how we usually manage a lacrimal gland prolapse, and this is very common what we see, but because nowadays I see many cases of dermatochalasis are having associated lacrimal gland prolapse. So along with the blepharoplasty, you need to treat, and before treating, you need to evaluate it very well, how much amount of gland prolapse, whether it is only the orbital part of the gland that is being prolapsed, or it is both the orbital and the palpebral part of the gland is prolapsed. If it is only the orbital part of the gland, you don't have to do such a major surgery. But if it's a palpebral, you really need to push it deep down into orbit so that it does not come back again. Then you excise the fat, and once you excise the fat, this is the LPS, and then you just need to close it. So this is how you manage your lacrimal gland prolapse. And this is a girl you see that following the lacrimal gland prolapse. This is a pre and a post-operative. But what you see here, you can see this prolapse along with so much of skin excision could be managed very well here. I have excised the skin, but not the orbicularis, because she is young girl and she already has a thin skin. Next, blepharoplasty combo is when the patient comes to you with a phenylephrine test positive, and you know that this is the patient who are having small amount of ptosis, and the only surgery you need to do is the upper lid blepharoplasty with the Muller's muscle conjunctival resection. So this is a very nice approach to manage ptosis of approximately 1 to 2 millimeter. In my hand, I feel approximately 6 millimeter of Muller's muscle conjunctival resection gives a correction of approximately 1 millimeter of ptosis. And this lady had a MRD1 of 3, so she was having a ptosis of approximately 1.5. So I have decided to excise 4 millimeter on either side. That means 8 millimeter of this Muller's muscle and the conjunctiva. So the first step is you need to separate it from the LPS. You don't want to have the LPS because it might lead to an overcorrection, because this is a posterior approach of plicating the LPS. So what you do, so once you measure approximately 4 millimeter, you put a running suture, and this is the suture that I am using is a 6-OPDS. You can use even the other monofilament. Sometimes I also use a plain catgut. And when I use the catgut, usually I give a double row, but you can also give a single row. So this is, I'm going a little fast here. So this is how you give either a single row or a double row. And once you come out, you extract the knot outside. And then you cut the amount of the tissue that has been clamped. That is 8 millimeter, which comes to, 4 plus 4, that is 8 millimeter. And in order to correct approximately 1.5 millimeter of the ptosis. So then you also, what I usually do, whatever tissue I usually cut, I usually try to re-examine, which helps me for correcting my future surgery, whether I have only taken the Muller's or only the conjunctiva. And I send it for biopsy. This is not a routine step, but only to make my surgery more perfect. So see, even with so little amount of cut, you can see it looks much hyper correction, but ultimately within a 3 months time, it looks a much adequate correction. So in my hand, I feel that approximately 6 millimeter of excision gives a correction of 1 millimeter of ptosis. So next is lateral hooding, which is very common in dermatochalasis, and which is a pure aging change where there's a loss of skin elasticity, which worsens over time. And there are different ways. Here you can see you need to excise lots of amount of tissue. The most common is the Bellin-Pierce technique, where they go up to the eyebrow, starting from the medial part of the canthus, and you have to shape it something like an almond. But what I have designed, that I feel that the best way is the point C that you'll be seeing. This is known as an extended blepharoplasty. So the first is what I have already shown. You mark the point A, that is the where you want to have the lowest part of your marking, that is the lead crease. This is point B, 6 millimeter, and the point C is the most important. This point C, which lies in the lowest part of the hooding, and the rest is okay. You ask the patient to look up in approximately 1.5 to 2 millimeter when it touches this the highest point. You need to mark the D, and then you excise it as a crescent. So once it is excised, then you remove the skin, you remove the muscle, you remove the fat, and then you can give a good correction of, which is known as an extended blepharoplasty, where you can see this has come down approximately to the lowest part of the hooding, and you can see this pre and post-operative picture. And patients like this, here it is, they have ptosis, they have got fats in all the direction. Here I do something like a W suture. Here in the W incision, you need to you need to excise more of the lateral part because they really have a lateral hooding, they have a ptosis. So here you can also plicate the LPS. This is the LPS that you can see here. And in my hand, 8 to 10 millimeter plication corrects 1 millimeter of the ptosis. And sometimes I also heard in one of my senior where he feels that 15 millimeter application in his hand corrects 1 millimeter ptosis. So it is very individual, but what I feel that a maximum 10 millimeter gives a 1 millimeter of the ptosis correction of the application. So this is what many a times we also plicate during a blepharoplasty procedure. These are the 3 sutures which we put for plication. And once this is being done, then rest of the steps are same like any of the blepharoplasty procedure. And this may not give a very good aesthetic correction, but yes, functionally it helps it because the slash ptosis is corrected, the ptosis is corrected, and also the lateral field of vision gets corrected. And the next blepharoplasty combo is when you have to do a eyebrow surgery, because I feel that they are the most important and expressive feature of the face. And if you look to the eyebrow mapping, the medial end, it lies in a vertical plane, passing through the alar base, and the lateral end, it lies in an oblique line, which pass to the right to the lateral part of the lateral canthus. And most important that both the medial and the lateral end of the eyebrow should be in this one same plane, and the highest point should be at the gap between the medial 1/3 to the lateral 1/3. And we should always remember the gender variation, because the male eyebrows are much thicker and they are less arched as compared to the female eyebrows, which are at a much higher position as compared to the male. And there are different shapes of the eyebrow, but I have already mentioned that whether it's the eye shape or the eyebrow shape, all are fabulous. They look well in everyone's face depending upon the facial configuration. And it can be managed non-surgically by chemodenervation or by filler, or it can be, corrected surgically. But these are the 4 major muscles that we need to approach. Whereas Dr. Usha has mentioned, the only elevator of the eyebrow is the frontalis. Yes, the orbicularis, the posteriors, and the corrugators. These are all the depressors of the eyebrow. So this can be done by a very simple operation as a blepharoplasty combo, where you first do the blepharoplasty procedure, and then this is being followed by an internal bropexy, which is nothing great, that you only need to put a 5-O monofilament suture, which can be a nylon, it can be proline. You need to lift this roof and this sag tissue approximately 10 millimeter above the superior orbital rim, and you need to fix it to the periosteum, which can be done through an internal approach, which we call as the internal bropexy, or also you can do by external approach. There are numerous external approaches. So this is how you see this lady. She comes to me for a blepharoplasty, and then when I see her, this is what I have seen, and this is what I have done, the internal bropexy, and what I have already mentioned, the mapping. So the medial end should end here. That is a line passing up to the nasal ala and the medial part, and this lateral should be up to here, and the highest point should be between the medial 1/3 and the lower 1/3. So when you do such surgery, you should always try to maintain the anatomy that they have. And sometimes along with the internal bropexy, like you also need to excise the depressors, which Dr. Usha had already mentioned, the corrugators and also the posteriors. These are the corrugators and the posteriors. You need to find them because these are very thin group of muscle. They all insert into the skin. So you need to expose them. You need to expose the corrugators, the maximum amount of the depressors and the posteriors and the corrugators are being possible. You need to excise. But once you excise, you need to fill up the gap. You cannot keep a gap here because this will lead to scarring and this will lead to puckering. So the fat that you excise during the blepharoplasty, the same fat I used to replace, I put it here so that it does not lead to a post-operative puckering. And this is what you see. As I have already mentioned you, this, extremities, the medial and the lateral, whatever surgery you do, it should be in the same plane in order to maintain the symmetry and the highest point between the medial and the lateral 1/3. I'll go very fast here because I have been given only 15 minutes. So epicantoplasty is sometimes when there are very prominent epicanthal fold. It can be managed in different ways. But for the beginners, I feel this is a very simple way. You just excise a crescent and it gives a beautiful correction. So along with the blepharoplasty, what you need to do, you excise this crescent of skin. And the most important thing, you need to do application of the medial palpebral ligament. So this is the medial palpebral ligament, which you need to shorten. And this is a very simple step. You can, in fact, in any of the Asian eyes, you can combine this, excise this crescent and do a little plication on the MPL. And this gives a very good, correction of the epicanthal fold, which gives a pseudo-isotropia appearance in such patient. So once it is being done, the rest of the steps are like the normal blepharoplasty, and depending upon the epicanthal fold, whether it's a mild, medium, severe, what you need to do, you need to plan the surgery. And one of the common way is what of doing is a YP-plasty, where you give the incision in the form of a Y and close it in the form of a V. Along with it, you also need to do application. So this is a very simple step. So whether you do a crescentic removal or you do application, a simple procedure corrects. And the most important, see, the caruncle is not seen here, but the end stages where you can see the caruncle, as you can see this doctor out here. So these are the different ways, and a little bit, I'll go just take 1 minute extra for the lower eyelid blepharoplasty. Again, when I say a blepharoplasty, it is always a reductive form of surgery where you need to excise the skin, muscle, and the fat. But most important is the anatomy out here, which I'll be coming to here. And this is usually done for a double convex deformity, which is characterized by the prominence of the orbital rim, the lengthening of the lower lid, and also the herniation of the fat. And this surgery is basically, which Dr. Usha has already mentioned, we have got 3 fat beds, the medial, the central, and the lateral. And then you have this inferior oblique muscle between the medial and the central. So preferably we go by the transconjunctival approach. And once you go by the transconjunctival approach, you cut the orbital septum, the 3 fat pad comes out. But if you look very carefully, can you see here, this is the inferior oblique muscle. This muscle which lies between the medial and the central fat bed, and you sure that you should not damage this muscle. And you need to form 3 pedicles. Nowadays, we don't excise. What we do, we form the 3 pedicles because we transpose this fat down to the mid part of the maxilla, that is down more beyond the swoop. And this fat pedicle actually acts as a filler, which forms the teardrop. So basically what happens, there is a loss of the tissue along with the prolapse of the fat, which leads to disappearance. So we do not excise. Sometimes we just titrate some amount of fat, but this needs to be repositioned. So to reposition down into the midface, you need to release the orbitomallear ligament, and you transfer this orbital fat, you release this orbitomallear ligament, and then this fat is transferred down into the midface. So this is how we do a lower lid blepharoplasty. It is done classically in most of the cases. And once it is being done, and then you suture it, and then it with a monofilament, which can be either a nylon or it can be a proline. And these are the beautiful results you can see that is following the blepharoplasty. What I want to show is this effacement of the lid cheek junction. So if you have your own fat, which works as a filling agent, it gives a very beautiful effacement, and you don't get a post-blepharo hollowness. And sometimes in elderly, we also do a lateral cantopexy. We tighten the lateral canthus, which gives a much better lift, a much better correction, as you can see in these patients out here. And sometimes we also need to do externally when there's too much of skin. Like Usha was mentioning about the soup lift, the smash lift. Yes, with the external approach, it becomes a much easier. So same technique, the 3 fat pedicle you make it, but laterally, externally, when we do, we cut the lateral fat pedicle, and then along with it, we just expose the smash orbicularis complex, and then this is being lifted. So once the lift is smash orbicularis complex, what happens? It gives something like a mini facelift. So this is a wonderful technique, as you can see in this lady out here. Just after the surgery, you can see, look out here, this whole of the mid face also gets lifted, and this you can see it is much sagged here. So the whole, it gives a very nice lifting effect, whether you see in the, the frontal and the different lateral view, and gives a total change in the whole facial configuration. So with this, I end my topic on the blepharoplasty. So once again, thank you all the members of Chandigarh Ophthalmological Society for giving me this opportunity.
Thank you, Dr. Kasturi, for this wonderful talk. And she has been very kind to except that she would be welcoming some questions. So if there are any questions, she'll be happy to answer. Though normally we don't have a question answer after a keynote address, but Kasturi has welcomed. So if there are
Thank
any
you.
questions.
Yeah, thank you, Dr. Usha. The first question will actually go from me. So, Madam, I wanted to ask you a question. You always talk about transposition of the fat post blepharoplasty, but there are some patients, at least, who come in who've been so troubled by the under eye fat that they really want to see a concavity in the under eye area. So I have had actually some patients in the past who've come back and said that this fullness has to go completely. I want to see a hollow. So we've tried to even explain that creating a hollow will mean that you'll need to do filler all your life, probably. But they've got so fed up looking at that bulging area and that convexity around under the eye that they want to see a concavity. Do you see patients like this? And do you still go ahead and do a repositioning of the fat below the tear trough or above the tear trough ligament in these cases?
Yes, and Dave, so this is what initially all my cases I used to do excision. I think Manpreet must be also remembering when he was with me, or every case we used to do excision. But now what I have realized when I look back to my own patients, yes, at that moment they look very nice because they are young. But after 10 years, when they comes to you and with already the skin changes coming, you can see, I'll show, I think in my next presentation, you can see the hollowness becomes so prominent. Even when they animate in the smile, it leads to a very bad look and along with the sagging of the skin. So a counseling is very important, like what we say, when we do a LASIK procedure, when we say that in the LASIK undercorrection is a blessing in disguise, that means till a very late age, you don't need a reading class. Exactly in blepharoplasty, the same counseling, I say that if I use your own fat as a filler, this is a blessing in disguise. Today, you may not like that a little, what to say, filling up of that area, but within 2-3 years, you look much better because slowly, everything is gravity dependent. So the sagginess comes faster and the hollowness, and especially in Indian eyes, the pigmentation is very high if you excise all the fat beds. So you really need to counsel them.
Thank you, ma'am. The next question is from Dr. Raman.
Well,
Yes,
Dr. Kasturi, it was a wonderful, wonderful presentation as always. And actually, we were mesmerized, all of us. And we not only need to learn the surgical techniques from you, but also the way of presentation, how you make it look so easy, and with all your, conceptual and pictorial things. That's really wonderful. Dr. Kasturi, actually, we just want to know how common is that you see lacrimal gland prolapse in your cases of blepharoplasty, who come to you for blepharoplasty, and do you really need to get a CT scan done in most of these cases?
Raman, this lacrimal gland prolapse is really common, especially in Asian eyelids. So initially, if you ask me 5 years before and 5 years now, 5 years before, I was also not very aware that it is so common. In spite of doing an extended blepharoplasty, I see that some amount of swelling is still present. But now what I have realized, like now in my last 5 years, what I have been doing, I try to evaluate if there is any lacrimal gland prolapse, but both in the palpebral and also in the orbital. Orbital is very obvious, but during the intraoperatively also, I try to excise the orbital fat and see if there is little exposure of the lacrimal gland. Even if I see, and sometimes routinely, if I see any thick lead, heavy lead, bulky lead, I routinely, what I do, I put those additional sutures that I was showing, where it passes through the capsule of the lacrimal gland and up to the periosteum, and I form a barrier so that this does not come out. And I'm much happy with the results. And that swelling, that bulkiness is not seen.
So you mean yeah, go ahead, please.
And even I feel that it is very common, which I also used to miss it. And because in spite of doing a very beautiful blepharoplasty, I see that lateral hooding does not go off. So once I started this technique, I don't see the lateral hooding also. And the patients are also much happy.
So maybe what I understand is, even if there is not an obvious lacrimal gland prolapse, but once we do a blepharoplasty and we remove the excess fat, we may find a lacrimal gland which may look prominent thereafter. So there's no harm tucking it on the go, in the first go, so that you have a better result post-operatively. Is
And
that
you
so?
know, you have to do this test, what we do for like a Verix test. You need to ask the patient to see and see whether due to gravity it comes. Every patient I do that.
And how often do you get the CT scan done for your lacrimal gland evaluation?
Not very often, not very often, but especially in young people, I do it because when it is not common. In young, when I see girls a little prominent, then I do it because it is very common amongst the elder population, but not much in the young population. So if I see anyone below the age of 35 or so, then invariably I ask them a CT scan just to be in the safer side.
One question for the panelists, especially those who are in the private sector. If a patient comes for blepharoplasty or dermatochalasis with mild or moderate ptosis, do we charge for one procedure? Do we charge for two procedures? Or do we charge for a procedure with a higher cost? Because I guess ptosis is being charged higher than that for a blepharoplasty. What do you say, Dave?
So it depends really. I mean, I don't think there can be any one answer. It depends on the city. It depends on the paying capacity of the patient. It depends on a number of factors. It depends on pre-COVID times and post-COVID times as well. So there can be a financial, it's a financial and commercial question more than a clinical question in that sense. But typically under ideal circumstances, when we work at top class hospitals, they will charge this as two procedures. So as a result of which you will charge this as two procedures and this will get added. And in fact, we've had patients in whom the blepharoplasty part has been paid by the patient for someone who's developed an aponeurotic ptosis, so that's been a cash payment, while the aponeurotic ptosis was paid for by insurance as well. So therefore, writing down the two procedures, I think what's important is, at least from a medical legal standpoint and also for the patient to understand the work that we've put in, billing it as two separate procedures, even if you have to bill zero for one of the procedures, at least lets the patient know कि इन्होंने मेरा एक procedure किया, दूसरा free में कर दिया, rather than us going ahead and combining all steps into one, which makes the patient feel कि इन्होंने तो कुछ भी नहीं 15 मिनट में निकाल दिया मुझे OT से. So that's what I think.
What do you say, Dr. Kasturi?
I charge for both.
Charge for both, okay. So I guess sometimes we need to suggest them that, okay, we'll do one free, or you charge the higher one. Again, it all depends upon the counseling. And sometimes, as you say, yes, you can charge for both. But then it all depends upon the financial position of the patient and the counseling and the city or the type you are going into.
The next question is coming in from Manpreet.
Actually, there is a question in epicanthoplasty. How much skin can be excised safely?
Yes, Manpreet, you have also done epicanthoplasty, no?
Yes, ma'am. But the question is for you, ma'am, from expert.
What I do, I usually measure, I hold the medial canthus, and the point where I want the skin to go, I just try to hold it with a force and pull it to the maximum limit medially to see. So the amount of pull and which does not give too much of, tension to the skin. So that is the maximum limit. So depending if the MPL is too slack, then definitely you have a bigger amount of epicanthal fold. So you just hold the medial end, pull it lateral end of the epicanthal fold to the maximum medial point without tension. Where it ends, that is the medial end of the marking. So every individual will have a difference.
I think it's an on-table decision and taken on the basis of the elasticity of the epicanthal skin.
But it is always advisable to placate the MPL.
Yes.
I usually do. Textbook says that if the MPL is lax by 5 millimeter, then if you have an MPL of 5 millimeter, then you go for placation. But whether it's a 3 millimeter, 10 millimeter, I usually placate it along with the skin.
Dr. Kasturi, just a passing thing. Actually, yesterday I was attending a Middle East Ophthalmological Society, and there they were discussing about the blepharophimosis correction, medial canthoplasties, and the stage 1 of blepharophimosis correction, and about this MCT plication. So there was a concern about the kinking of the canaliculi if you plicate the medial canthal tendon, whether in case of epicanthal correction or in cases of telecanthal correction in blepharophimosis. What's your take on that matter of canalicular kinking? Because we are shortening the medial canthal.
This is one of the complication when we do a transnasal wiring. So transnasal wiring usually leads to some amount of canalicular kinking, but with MPL plication, it does not. I have not come across because it doesn't involve the canaliculus as such. In fact, it gives a more straightening of the MPL. I mean the canaliculus. But definitely, if you use a transnasal and you make a burr hole and goes to it, then there is a chance because you pull it inside the bone.
Right.
Should we move on? In the interest of time, should we move on to the next?
I'll take up from here. I would like to introduce all my speakers now. So our next speaker is Dr. Debra Shom, and Dr. Debra Shom is is my slide visible? Am I heard?
Yes, ma'am.
Yes, ma'am.
Yes. Dr. Debraj is the co-founder and head Institute of Aesthetic Surgery at Aesthetic Clinics. He's the first and only surgeon in Asia to be American board certified in facial cosmetic surgery, diplomat American Board of Facial Cosmetic Surgery. Dr. Shom has more than 60 research papers and he has 2 US patents. He has won many awards and honors such as the Best Plastic Surgeon in India, the Best Cosmetic Surgeon in India, Breakthrough Innovation in Facial Plastic Surgery, and Indian of the Year for 2017 at the 8th Annual India Leadership Conclave and Indian Affairs Business Leadership Awards in 2017 and the Davies Foundation Grant Award by the Royal College of Surgeons. This is very impressive. And Dr. Shom is also the best-selling author of Dear People with Love and Care, Your Doctors, which has sold more than 15,000 copies in 2019. And recently, he has also got as the recognition for those training, oculoplastic surgeons training. I think Dr. Debraj can tell us more about that as we go on. Our next speaker would be Dr. Vinay Keshavmurthy, and he's an assistant professor in the Department of Dermatology in PGI Chandigarh. He's an active member of many societies, the International Dermoscopy Society, and his clinical areas of interest include dermatosurgery, dermatoscopy, bullous diseases, connective tissue diseases, pigmentary disorders, and systemic dermatology. He has published many scientific articles and has a total of 210 scientific publications to his credit. He's a deputy editor of Indian Dermatology Online Journal and Pigment International. He's also the editorial board of Indian Dermatology Online Journal and Pigment International. After Dr. Vinay, this talks will be given by Dr. Feroz, and Dr. Feroz, we all know, she's one of our oculoplastic surgeons, and she is the director of Horus Specialty Eye Care Bangalore. She's trained in oculoplasty, orbit, and ocular oncology at LV Prasad Eye Institute, Hyderabad, India, with Dr. Santosh Unawar, and Wills Eye Clinic, Philadelphia, USA, and Dr. Jerry Shields. Her focus areas are retinoblastoma, eyelid, and conjunctival tumor. She's known for her surgical expertise, oratory skills, passion for innovation, received many awards, including the American Academy of Ophthalmology Achievement Award, Asia Pacific Academy of Ophthalmology Achievement Award. She's also visiting consultant in tertiary referral hospital in China. Recently, she has been elected as a member of the scientific committee by the AIS. And followed by we have our other panelists, Dr. Raman Mittal. He's done his fellowship in oculoplasty, LV Prasad Eye Institute, Hyderabad, affiliated with Grewal Eye Institute, Chandigarh, Brar Eye Hospital, Kotkapura, and Thind Eye Hospital, Jalandhar. Expertise in oculoplasty, ocular oncology, and aesthetics. We have Dr. Manpreet Singh. Is the assistant professor at the Department of Ophthalmology, Advanced Eye Center, PGI Chandigarh. He does research in ophthalmic plastic surgery with a special interest in lacrimal drainage disorders. So with this, I would like,
I'm sorry to interrupt you here. Actually, regarding my introduction, I would just like to mention that I have left the associations of the above mentioned institutes like Garewala Institute and Tendai Hospital, though I really am honored that to had an associations earlier. So just need to clarify that at present I am on my own in iPlast Hospital, Eye and Plastic Surgery Center in Chandigarh as well as in Amritsar.
Thank you, Dr. Raman, for updating us your recent affiliations. And with this, we will. This will be our program. First, I will invite the next speaker, Dr. Debraj Shom, and he'll be talking about under-eye combination treatments. So, Dr. Debraj, please.
Thank you, ma'am. Thank you very much. And I'll be sharing my screen right now. I trust my screen is visible.
Yes,
very much visible.
Yes, it's visible.
Okay. Thank you, ma'am. Thank you to Chandigarh Ophthalmology Association, and thank you to all my dear friends and colleagues for having me here. It's always difficult to be speaking immediately after Dr. Kasturi, and unfortunately, that onus is on me today. So my name is Debraj Shom. We run a chain of clinics called the Aesthetic Clinics. We are in 6 cities in India at this moment. And the topic that I'll be speaking on today will be under-eye issues. And I'll be trying and using a combination of non-surgical as well as surgical methods to try and address the under-eye issues. The financial disclosures are in place. I have been a key opinion leader with Allergan for the past 15 years and a trainer for the Asia Pacific region. I'm also a key opinion leader and a trainer for MERS, as well as a key opinion leader and a trainer for Aptos, which is the company which makes facial threads. And obviously, all of our results look better because the dermatology team at the aesthetic clinics, led ably by Dr. Inky Kapoor, makes our results look far better than they otherwise would have been. The most important thing to remember is that the eyes say it all. And that is the reason why ophthalmologists all across the world are playing a significant role in facial aesthetics and facial plastic and cosmetic surgery. In fact, the one thing that I'd like to say is that out of the number of diplomates that we have, 188 diplomates of facial cosmetic surgery that we have globally at this moment, the American Board of Facial Cosmetic Surgery, almost 40% come from an ophthalmology background. And the reason that facial cosmetic surgery and facial plastic surgery is being revolutionized by people with an ophthalmology residency training, at least in the Western world at this point, is because the eyes say it all. If you look at this aging superstar and you look at this superstar in his late 30s and now in his early 50s, you can see that the rest of the face is almost the same, but the eyes say it all. And that is the reason that we've been trying to make sure that more and more ophthalmologists get into facial cosmetic surgery. And it is a great privilege and honor that our fellowship in facial cosmetic surgery has now got approval from the Maharashtra University of Health Sciences, with MS ophthalmology being one of the ways to get into this post-residency fellowship program. So I think that's a big thing in terms of getting facial cosmetic surgery approval at the MCI level. Now, when we think of the OG curve, we realize that this is a S-shaped curve, and this curve is seen the best in young women. Young women, when they are looking at about 45 degrees, you will see that there is a concavity below the eyes, a convexity, or the malar convexity as it is known, followed by another concavity and then the convexity of the mandibular region. So this is this S-shaped curve, which literally makes people look young and beautiful. And the symmetry of the eyes play a very important role in beauty. So when you look at this beautiful model, you see that she's got beautiful almond-shaped symmetrical eyes. In fact, the right and the left eyes are almost mirror images of each other. And in fact, because you've been paying so much attention to the eyes, you've missed out that the lips have an asymmetry. So the left part of the upper lip is nowhere as well developed as the right part of the upper lip. And the reason is the filler person who's injected filler has not paid too much attention to this particular part. So the nuances of the face are governed by the eyes. And that's why, like I said again, ophthalmology, having practiced millimeter surgery, which has expertise in millimeters, are at a unique position of providing symmetry for the entire face. Now, if we think of facial aging, what exactly is facial aging? Facial aging is mother gravity acting ever so kind, and mother gravity pulling all of us downwards and medially. So if you think about mother gravity pulling us downwards and medially, essentially anti-aging would be us pulling the tissues upwards and laterally. And that becomes our first focal point of any anti-aging talk. Now, the under eye area is a very unique area, as we know. If you look at the thickness of the under eye skin, you will see that it is thinner than in any other part of the human body. And therefore, the under eye area shows the earliest signs of ill health, stress, and aging. And if you talk to a dermatologist or a specialty which doesn't do surgery, you would tend to think that fillers are a panacea which would solve all. And obviously, if you spoke to a plastic surgeon, you'd believe that blepharoplasty is a similar panacea. But the fact of the matter is, diagnosis and treatment of under eye problems requires a systematic diagnostic approach and individualized treatment. They say that the eyes will never see what the mind doesn't know. And as you super specialize and concentrate on the under eye area, you will slowly and steadily begin to see it all and begin to see how your repertoire could impact patients and the way their under eye looks. Now, if you look at this particular patient and I asked you a simple question, medical treatment or surgical treatment or both, you'd most likely turn around and say surgery, because the majority of people on this particular podium will be from an ophthalmology background and they have been trained in oculoplastic surgery. But you'd have to agree that the texture, the tone, the blemishes, the scars, and most importantly, the quality of the skin cannot be improved with surgery alone. So therefore, if you're looking at a one-size-fits-all sort of strategy, really, this is not the way to get into aesthetic surgery. In aesthetic surgery, every millimeter is an inch, and every millimeter needs to be taken care of, and every point of improvement needs to be taken care of. Now, so the problems that are there in under-eye rejuvenation makes the diagnosis of problems important. And we've actually decided to make this in accordance with topography. So everyone understands these particular terms: troughs, tunnels, valleys, and mountains. And this is the subject of a recent paper which we are just compiling and sending across to OPRS, basically trying to compare the under eye tissues and breaking them into troughs, tunnels, valleys, and mountains so that we can systematically teach the younger generation how to treat these. And it's important to obviously titrate and individualize these and treat them accordingly. So in general, you know what the troughs are: the tear trough deformity. Tunnels are the problems created by hypertrophic orbicularis oculi muscle, and we'll show some photographs of the same. The valleys are caused by the displaced SOOF, and the displaced under eye bags cause the so-called mountains. Now, if you look at these patients, and what I'm going to do is I'm going to actually take you through the life cycle of each of these patients. This lady comes in, she's 28 years old. She wants to be a model. She is an existing model, but she wants to be an actress. And she wants to know, how can I go ahead and look younger, more rejuvenated, etc. It's important to understand that, yes, she has a tear trough deformity, but no, we would probably be overshooting the mark if we go ahead and suggest surgery in her of any kind. Fact of the matter is, you can go ahead and kill a mosquito with dynamite as well, but the risk-reward ratio will not stand in your favor, and therefore it becomes very important to look at collateral damage whenever you practice surgery. So therefore, in this particular patient, we've done a simple filler. In this case, the filler is Juvederm Ultra Plus, which is a hyalocross filler as we know it. This is done with the bevel kept downwards. It's a very forgiving filler, except for the fact that it absorbs a little bit of water. So undercorrection is the norm here. And you should try and correct these tear troughs to about 80% of their capacity. And this is the patient, the next time when the patient has come approximately 2 weeks later, and this patient has been on follow-up, repeated filler injections every 2 years, and she's been with us for almost a decade. And I can assure you she looks better at 38 than she did at 28, because the incremental effect which can be created by millimeters over a period of time is what makes aesthetic surgery. So don't try and do everything at one shot, but as steadily you go ahead and improve the patient, you will have traversed a big journey, and that big journey is called beauty. Now, similarly, if you look at this particular lady, again, 28, 29, the type of person that we see in people in when they live close to Bollywood, everyone wants to be a star, and she wants to go ahead and look better. And again, in this particular patient, the most important part of this filler injection is that you can see that in the inferior eyelid, the lid cheek junction has reduced. So if you look at the lid cheek junction on the other side, which is the line which is drawn from the lid margin till the tear trough, you can see the lid cheek junction on the post photograph is actually reduced, which gives rise to fuller eyelids. And fuller eyelids, remember, are a sign of youth. Making eyelids cachexia actually makes people look older. Now, there are some patients who, when they smile, you can't see their eyes. So either you see their teeth or you see their eyes. But ideally, it would be nice to see both. And so from that perspective, if the hypertrophic orbicularis oculi role is something that needs to be treated. Now, this is a slide that I've got from Milind, and Milind has injected this in this particular manner. But in general, I would go ahead and inject it differently. And we do this in almost every patient, because what happens is, as you grow older and your brows are deflating and coming down every single day, essentially what is happening is, if you looked at your earlier photographs and you look at your photographs now, you'll find that over a decade, between the 30s and the 40s, your eyes are becoming smaller and smaller. So therefore, trying to allay this hypertrophic orbicularis oculi and making the eyes open up wider makes everyone look much better. And that's something that should be concentrated on. Now, this particular lady is especially interesting. She came in, she's 28 years old. She came in and she wanted squint surgery and ptosis surgery. She had been advised by a couple of oculoplastic surgeons, as well as general plastic surgeons, who wanted to do ptosis surgery on her. But if you look carefully, you can see that there's a significant amount of asymmetry between the right sides of the face and the left side of the face. On the right side of the face, the right eyebrow is higher than the left eyebrow. You can also see that there is an inferior scleral show there between the lower eyelid and the lower limbus. But you can see that both the corneal light reflexes are almost in the center of the pupil. So clearly there is no squint as such. But can you really address this patient? I mean, one way of looking at it is, someone suggested a lateral tarsal strip for the lower eyelid and then a ptosis surgery of the upper eyelid. But fact of the matter is, I'm not a good enough a surgeon to correct 0.5 millimeter predictably in every patient. And remember, in a 28-year-old who wants to look better before a HD camera, once you do a surgery and the LPS is tightened even through application surgery, fact of the matter is, there is going to be some amount of lid lag, at least for some period of time, and the patient is going to be very, very unhappy. So these are the thoughts which should be entering your mind as you're going ahead and making a decision. Is this a surgical patient or is this a non-surgical patient? Now, this patient becomes even more interesting when she smiles. And when she smiles, you see that the asymmetry on the right side of the face and the left side of the face extend throughout the skull. So the left eye is becoming significantly smaller when she's smiling. You can also see that the right malar fat pad is very different from the left malar fat pad. And it is this asymmetry which needs to be addressed. As they say, in beautiful people, the right and the left halves of the face are almost like sisters, whereas in the rest of us, they are like cousins. So therefore, you've got to convert the right and the left halves of the face from being cousins to being sisters of each other. Now, to do something like this, you can do surgery, and maybe you're a good enough surgeon to do that. But the thing is, if you do this in 100 people, will you succeed in all 100? That's the point of aesthetic surgery. So therefore, we went ahead and did some non-surgical treatment. And you can see how the before and the after looks. The eyebrow has come down. It looks more symmetrical. There's now an inferior scleral show on the left side as well as the right side. When she's smiling, that ugly roll, which is the hypertrophic orbicularis oculi, has gone. She's obviously had some treatments to the face as well, which is making the entire face look a little bit more symmetrical. The face has also been lengthened, if you look very carefully, because of the chin fillers which have been done. So all in all, a lot of symmetrization has been done, because beauty is all about symmetry and proportion, as we know. So what we did is 2 units of Botox just below the central line of the pupil on both sides, as close to the tarsus as possible, as close to the lid margin as possible. So you're injecting pre-tarsal. And then you're injecting fillers, in this case, a Juvederm Ultra Plus XC, again, a hyalocross filler, which will swell up, so you need to undercorrect. And the moment you do that, you can create this approximately about 2 weeks later. But the fact is that when she smiles, that's when the difference really comes into play. She's decided against surgery. We are glad that she decided against surgery, and she's been on treatment since then. And one of the presentations that I do is I tend to track all our patients over the last 12 to 15 years and show how, as they've gone incremental changes in their features, they look far better in their 30s and in their 40s than they actually did in their 20s. Now, this person comes in and she's a 33-year-old, and she comes in with what you would call a surgical blepharoplasty-like patient. So if you see, there is obviously some facial dystopia again. The right side of the face and the left side of the face are clearly not the same, and that's emanating from the way the skull has developed. You can also see that the left eyelid eyebrow is raised, and the under much deeper. But my question to you is, can you do a bleph? Answer is yes. But how many times should you do a bleph? She's 34. average life expectancy, if you look in the middle class population in today in India, is approximately 80 years, because 69 is the average life expectancy of all Indians. So now, if she's lived half her life till now, how many blepharoplasties do you plan to do? Do you have enough repertoire in order to go ahead and try and do one blepharoplasty and make it last for another 30 years? I don't know the answer. So as a result of which, we said no surgery at this moment in time. Let's try and address this through fillers. And this is immediately post the fillers. So what you're doing is, your choices as a surgeon are either you remove the fat or you camouflage the fat. We chose to camouflage the fat using a thicker filler. In this case, we are using a Juvederm Volift, and we are using the Volift along the lower part of the trough. And by using it in the lower part of the trough, you're actually changing the contour. You're removing the valley so that the mountain then gets hidden. And in that sense, you can see where the injections have been given, and you can actually see the pinpricks which can be seen in this particular patient. This same patient approximately about 2 weeks later, and you can see just correcting the eyelid makes such a big difference to the entire eyes and corrects the lid cheek junction and makes the person look much younger. Now, facial thread lift is a very important part of what we do, and we use different types of threads. There are some of these monofilament threads which are used in certain areas. There are some of these cork threads which are used in certain areas. There are some of these silhouette other threads which are done even surgically. Many people say threads don't work. I tell them guns also don't work, but that is for people who don't know how to use guns. So when you go ahead and use the non-surgical facelift, this is basically how it works. And what you're doing is essentially you're going ahead and performing a non-surgical procedure performed in the doctor's office. And by using this non-surgical cork threads, a cork thread is essentially like a rose stem with thorns all the way around. And these thorns tend to take attachment to the pads, the malar fat pads, and they raise the fat pads, and we get results which last almost 2 years with these non-descrepit threads. It is a little painful, but the patient has prilocaine and therefore can bear the pain. Now, the lasers are our lasers, and when we think about lasers and light therapy, if you are a plastic surgeon and do not have access to lasers, there is a significant amount of your results which we believe you're leaving on the table. And our two workhorses, or the light workhorses, are excuse me, the fractional carbon dioxide laser, which is used for skin rejuvenation, which is for removing the lines, the lines, the wrinkles, the small pores, etc. And the Q-switched Nd:YAG laser, which is used for pigmentation, under-eye pigmentation, melasma, etc., along with peels, etc. So in a patient like this, when you see him before, and then you see him after 6 sessions of trichloroacetic acid and lactic acid peels, and then 8 sessions of the Q-switched Nd:YAG laser, which is also called the Medlight laser, you can see the significant difference which can be created in some of these patients. And some of the patients also present with mountain bags like this Caucasian patient, but she didn't want surgery. And in these patients, if you go ahead and do fillers, followed by a session of carbon dioxide laser, you can actually tighten the skin around the fat bags and therefore prevent the fat bags from showing up. In some sense, you're going ahead and using an iron on your trousers and letting the trousers shrink just a little bit so that it fits you better. Similarly, you are basically allowing the under eye skin to shrink just a little bit, developing collagen and keeping these tighter. Now, some of these patients also come in with multiple other problems, right? So this patient has come in with under eye wrinkles, has come in with under eye dark circles. So a combination first with Botox and filler injections. Then you do the grid pattern, which is on the lower side, the carbon dioxide laser 3 days later showed this sort of a fractional grid. And then after 2 sessions laser resurfacing, see how the entire texture of the skin has changed. And even if we did surgery, we know for certain we would not be able to change the texture of the skin in this manner. Now, some patients come in with dermatochalasis. This is a 68-year-old who came in from Utah and Salt Lake City, and she wanted to look younger. Her only request was, can I go ahead and look like a young enough grandmother so that my grandchild allows me to go to his school and does not feel ashamed of taking me there? Yes, so she can look like a younger looking grandmother, and a combination of a blepharoplasty with a lower mid-face lift followed by a bropexy and carbon dioxide laser can make a significant difference in some of these patients, like the 66-year-old grandfather as well. Some patients, after you've done a blepharoplasty, before you have this, but after doing the blepharoplasty, the under eye skin is still crepey. You've removed the fat bags, yes, but there is still some amount of crepiness and folds, and people want that removed. And the laser resurfacing does a great job of fabulously changing the texture of the skin and making the skin below tighter in a predictable manner, which would not be possible just with surgical removal. Scars are something that we deal with regularly, and scars can also look much better with laser. And I hope a lot of you would have read this particular paper, which was published in the flagship journal of the American Society of Plastic Surgeons called Plastic and Reconstructive Surgery. And in this, we speak about an algorithm where we inject botulinum toxin prior to the facial scars being operated on. Then we perform a surgery, close this in layers, and ensure that the scar is everted, and then perform carbon dioxide laser along with certain skin creams to make patients look much better. This has been cited significantly by a number of our peers in the last couple of years in their papers as well. So some of these patients who come in with these scars, and this is a person who was operated along with our neurosurgical team, and when we go ahead and reconstruct the eyelid and put a prosthesis in place, and then work slowly and steadily on the scars over a period of time, you can actually take the person from the extreme left to the extreme right of the screen, and he was very happy, and it's been 10 years post this ghastly surgery that he had. Post-ptosis surgery also lasers, the pigment removal by the lasers is very important, as has been done in some of these patients, and these make the patients very happy indeed. Scars and the way they are treated with laser skin resurfacing. This is one of our other papers. This is just being readied for publication to the PRS. And 3,000 plus patients have been treated in the past 11 years. And they have been treated with laser skin resurfacing, especially in those patients who've undergone other types of oculoplastic or facial plastic surgery procedures as well. And as you can see, 600 of these patients have benefited with prior oculoplasty procedures. So I encourage all of you to work very closely with your dermatologist in order to get your results to improve. So in summary, beautiful eyes is equal to a beautiful face, and the under eye can be the first sign of aging. It's amongst the toughest areas of the face to treat well. I always turn around and say that I never performed cataract surgery except from my residency. 2003 was when I performed the last cataract surgery. That was still the toughest surgery that I have done. That is a surgery in which millimeters make a difference. And if you can go ahead and master cataract surgery the way a number of you have, there is no reason why you can't master facial cosmetic surgery. It is actually more forgiving than cataract surgery is. And therefore, diagnosis and treatment of all of these disorders can really lead to very good results. But the most important thing is, if the only tool in your toolkit is a hammer, everyone will look like a nail. And therefore, having a wide armamentarium of synergistic procedures ensures the best results. We train people regularly, and that is something which is very, very close to my heart indeed. I would like them to learn a little bit easier than I had to learn from so many specialities and with so many fellowships. And therefore, we try and treat patients. This is a training program in facial aesthetics that we perform, where a 14 days observership with us is arranged for. You can go to this website and look for the next training programs, which are available in October, etc. And this is the bestseller book which Dr. Usha was speaking about. This is an anthology, and this is an Amazon bestseller from last year. I encourage you to read it, especially in times where COVID is creating a significantly stressful sort of situation for all of us doctors. And anyone who's a doctor will feel really proud of the 34 doctors who've written stories in this particular book. I thank you for your kind attention and a very patient hearing. And thank you for having me here again. And I'm sorry if I've gone over time.
Dr. Kasturi?
Yes. Okay. Thanks, Deb. That was a great presentation. So I go back to my next presentation. So can you see my slides, all of you?
Yes.
Yes.
Am I audible?
Yes, you are.
Yes, you are.
So I come back to something very interesting, and Dr. Deb and Usha had already, covered quite a bit about it. I'm speaking about the fillers for the aesthetic use, no financial disclosure. So we all know that facial aging is a multifactorial, complex, three-dimensional, dynamic, and generally not uniform process with anatomical, biochemical, ethnic, and genetic correlates. So it occurs basically due to the combined effect of gravity, progressive bone resorption, decreased tissue elasticity, and the redistribution of the subcutaneous fullness. So what we see that in some place it is associated with loss of soft tissues, basically in the periorbital, the forehead, the malar region, and in some places you see hypertrophy of the fat, especially in places like this, in the lower part of the face, in the malar region, and also in the chin region. So these are the places where you have a hypertrophy. And so what we basically want is that we want a combination of a hypertrophy and also loss of tissue in order to have a balance between the two parts. And thus injection dermal filler, it balances between the hypertrophy, that is the depletion, and the hypertrophy, that is the deterioration it causes to the face. So when I talk about filler, the most common filler that we use is the hyaluronic acid. But I want all of you to understand that hyaluronic acid is something which is present in the body, and the skin itself accounts for the 50% of the total body hyaluronic acid, which is present more in the epidermis as compared in the dermis. So what happens when we age? There's fragmentation of the collagen, and this leads to a loss of the mechanical tension. And we all know this is because of the loss of the fibroblast. And we all know that the fibroblast is the main source of the collagen. So what I mean to say that as we age, there's lots of more of epidermal hyaluronic acid as compared to that of the dermal hyaluronic acid. So we have multiple different types of fillers, which Dr. Debraj had already mentioned. But a good filler is one which is easy to use, which is predictable. Most important that it should be well tolerated, having a range of indication and long lasting, but above all, it should give you a natural look and of course a natural feel. And the one which we commonly use in India are the Allergan product, which can be a Juvederm Ultra Plus or the Juvederm, the Voluma. This is basically the manufacturer, process is different for both of them, where on one side we have a long polymer, the high molecular weight Juvederm, which is basically the ultraplastic C, which Debraj was showing very well in his clinical scenarios. And on the other side, we have the short polymers and the low molecular weight, which we call it as a Vicross technology. So we all started with the Hyalocross technology, and now most of us are going to the Vicross technology. But whatever we do, whether it's a botulinum toxin or the surgery that I have shown you, or whether it's a filler, the most important part is a clinical assessment. And for the facial beauty, the most important is the symmetry. But here I want to insist that symmetry is not absolute, because look at the two parts of the face, it may not be symmetrical in elevation. So for the face, we say that the two parts are siblings, but what we want that the two parts of the lips should be a twins. We want a symmetry on both sides of the lips. So the best way, the simplest way to estimate the face symmetry is to divide the face into vertical fifth, and each fifth is equal to a distance between the two parts of the eye, that is from medial to the lateral canthus. So when we talk about symmetry, we say that that face is symmetrical, which can be divided into the 5 vertical fifths, and that is in the vertical plane. And in the horizontal plane, we have 3 parts, where the part 1, that is which starts from the tritium to the glabella. Second is from the glabella to the subnasally, and the third from the subnasally to mentalis. So if you have a symmetrical area between the 3 horizontal part and the 5 vertical part, then you call it a symmetry. So when we go for evaluation, when we evaluate by the aesthetic hierarchy, the first one definitely the full face analysis, which we call it the aesthetic hierarchy 1. But the second part which we want to evaluate are the 3 horizontal thirds that I have mentioned. And the most important being an ophthalmologist, it is the hierarchy 3, which is the evaluation of the periorbital part. So if you look at the lady out here, so these are the 6 steps of evaluation before you proceed with a filler injection. The first is the tilt. If you look to me here, the tilt is like, this is what I'm present. And if you look me from below, that means this is my past, where I look much younger. And if I look down, because of gravity, everything comes down. So this is my future. This is my future. This is my present. This is my past, and this is my future. So this is what you need to see in the tilt. And secondly, you need to see the snap. Snap means you need to see the laxity, the smile. When this lady smiles, if you see that there's any bulging out here, especially if you see a bulging somewhere out here, that means she already has some injection in this part. Then the squint is very important, because when we squint it, if you see that this part of the tear trough ligament becomes very tight, or if it projects out, that means you need to do a sub-incision before you go for the filler injection. Fourth is you need to pull and see whether the tear trough is very adherent to the skin. Then this part of the tear trough we usually avoid by giving a filler. And fourth is a push to know whether the fat goes inside, which helps you decide whether you do a blepharoplasty or you go for the injection filler. The next most important that you should have a standardized photography in every patient before and after the procedure, which should be at the straight face, the 45-degree and the 90-degree. And the most important is the preparation. The most important should have an aseptic and the antiseptic preparation. You should have a very thorough history of any pre-existing infection. And also, if you use a needle or a cannula, you should know you should aspirate before you do with the procedure and never touch the tip of the cannula. So when you go over the injection technique, the most common technique that we prefer is the threading. The next becomes a depot technique, which is the serial puncture, which we give either in an antegrade or a retrograde manner. It can be in the form of a fan or it can be a cross-hatching. So I want all of you to look to this animation out here. This is because I want to understand that, as Dr. Debrach mentioned, the eyes are the aesthetic center of the face. And the eyes are the focus where when we are talking and listening. And the most important that any irregularities or blemishes are noticed first in the eyes. So it is very essential when we think of aesthetic correction, the eyes should be the first part to be corrected. And for that, we ophthalmologists, we prefer to correct the tear trough deformity, which by definition is an oblique fissure like concave deformity, which arises from the tear trough ligament that separates the palpable part of the orbicularis muscle from the orbital part. Dr. Usha has very nicely mentioned the difference between a tear trough and the nasojugal. This is what I want. But before that, I would like to mention that the tear trough basically includes a combination of the grooves, deficiency, bags, festoon, laxity. So what Usha was mentioning about the tear trough, if you look to this part here, this prominent part here, this is a true tear trough, the correct tear trough, which is in the zone of separation between the palpebral and the orbital part of the orbicularis muscle. So this is the correct tear trough. And what Usha was mentioning about the nasojugal fold, this is a triangular depression that occurs, that lies between the levator levi aliginesi muscle and the orbital part of the orbicularis muscle. So this is an indirect tear trough. So one should have a very clear understanding and anatomical knowledge between a true tear trough and an incorrect tear trough. And this has been very nicely highlighted by a paper by Dr. Robert Goldberg, where he has shown the different hills and valleys which occurs due to changes in the ligamentous attachment, where he shows the three beautiful hollows that can occur with aging, which can be an orbital rim hollow, a zygomatic hollow, or the septal confluence. And based on this, the new concept of classification of tear trough has come out by Sadek et al., where type 1 is a hill, type 2 is a valley, type 3, you can see a combination of hill and a valley. The type 4, where you see a beautiful hill here, and valley in between. And the type 5 is a combination of all the. So if you look to these young, beautiful ladies from different ethnicity, you see the periorbital region, these are all oval. So when we are young, we have an oval area look. But as we old, because of the deterioration, because of the sagging, because of gravity, the oval structure takes a more of the round structure, which not only occur amongst the female, but also it occurs amongst the male. So what I mean to say, the tear trough occurs because of the change of a positive vector to a negative vector. And this is because of deflation, descent, deterioration, and disproportion that occurs with aging. And this aging signs can be both visible aging signs or the hidden aging signs. And the visible aging signs, it usually involves the skin, but the hidden are the ones which involves the bone and the ligaments. And when I talk about the ligaments, these are something that can be compared to the three. Like this are the osteocutaneous structure, which arises from the bone and inserts into the skin. And thus it separates the part into different fat component, in both in horizontal component and also in the vertical component. And one important thing I want to insist out here is that the ligaments are so important because anything lateral to this line of ligament leads to a lifting effect, which we call as foundation. And anything medial to this ligament, we do a much of a contouring effect, which we call it as a refinement or contouring. So a lateral to this line of ligament is basically a lifting effect or a foundation, and medial to this ligament, we usually do the projection or we do the contouring. And this is what when the patient comes to us and says that I need to lift, what the first point as an ophthalmologist or an aesthetic surgeon, I try to pull it laterally to see that how much amount of lifting I can do laterally in this lateral line of the ligament. And when I talk about tear trough, we usually inject into the trough area, and classically there are 3 points which we call as a TT1, the center point, the TT2, the lateral point, and TT3, the middle point. But remember, as I have already mentioned, every refinement should be associated or should be first started with a lift, that is with a contouring. And the most important point for contouring is a CK1 point. And this CK.1 lies on the arch or the zygoma, which can be a single point or a 3 point. And a small injection in this point gives a so beautiful lift that it not only gives a slimmer appearance, or it not only lifts the whole part of the face, or it gives an improvement of the tear trough, but also it opens the eyes, and also it gives a lifting of the eyebrow and the face as such. So another point which I want to mention, I think you must be knowing this lady out here. If you draw a line from the ella of the nose to the tragus, and another line from the lateral part of a mouth to the lateral canthal region, and a line which bisects this point, this main line in the center, this is known as the G point. I think in this session, we have many plastic surgeons out here, and they must be knowing what is the G point. This G point is the main point of lifting, which is done, or which is first approached when we do any part of the lifting, whether it's a tear trough correction or whether it's a mid-face correction. So when I was mentioning about the tear trough, these are the 3 classical points for the lift, for the refinement. And this is the CK1 point or CK2, CK3, which is for the lifting. But you should always remember that this is a dangerous zone, as Usha had already mentioned, because of this confluence of the internal and the external carotid artery. So Dr. Professor DiMeo has rightly mentioned that the tear troughs are not as friendly as the dogs. They can be as tricky as the cats, but they at times can be as dangerous as the lions, because they end up with so many complications in the form of ecchymosis, in the form of Tyndall effect, and the most dangerous being the blindness. So I really want all of you to understand the 2 concepts in the anatomy or in the arterial supply of the face. First, the area supplied by the internal carotid artery, and second, the area supplied by the external carotid artery. So when I'll just go fast here, so these are the main branches of the internal carotid artery, which the supraorbital, the supratrochlear, the lacrimal, and the palpebral. But what I want to show, the branches of the external carotid artery, which is the facial artery, and you should know the level, and you should know where this artery stays, because here the artery is near the bone. So in this part we inject superficial, or we inject in the part which is away from the bone, but as it comes in the face it becomes subcutaneous, and here it becomes subdermal. So when you treat the nasolabial fold, you have to go either deep or you have to be very superficial, or when you treat in this region you need to be deeper. So that's why in the tear trough you usually hit the bone. And secondly, the angiosomes, which everyone should know, because these are something very important arrangement of the blood vessels, which prevents some of the tear trough complications of fillers. And these are some of the wonders of tear trough that we see. You can see I have used a cannula, and you can see the immediate change in this lady in the tear trough, and also the fat prolapse just after the procedure. This is not a very good picture because the Botox has already been given, the before and after changes that you see, and the beautiful changes which we see, which can be managed even with a blepharoplasty, though I have shown you many blepharoplasties before, but also many of this condition can be even managed with the filler. And the most important, what Dr. Devbrach was asking me, that what happens if we excise and give them a concavity? Okay, when we do a blepharoplasty, the immediate results are very good, but later they come with a situation like this, when the concavity becomes so prominent along with the sagginess of the skin, and these are the post-blepharoplasty complication, where only you excise the fat, So I prefer that most of the fat should be transposed and should not be excised totally. And in such situation, we have the filler with us. So these are the post-blepharoplasty augmentation, where initially all the fat has been excised, and now with a filler, I usually prefer using a cannula because this is a dangerous part of the face, which Usha has already mentioned. So with a cannula, you can nicely fill up all the hollowness that has been induced by the post-blepharoplasty procedure. And this is how the same lady, you can see the whole part has been filled up so well after the filler injection. And the same lady before, you can see where you can see so much of hollowness and changes in the skin. And even when she animates, she smiles, you can see the skin looks much better, much fresh as compared to what she was before. Another lady who had blepharoplasty with the excision of all the fat bed, and you can see the amount of hollowness and the pigmentation that has been created. And then the same procedure, the first, what I have mentioned is the lift. The contouring is first being done, and this is being done by the refinement, that is the 3 points. So I'll go a little fast. So these are the contoured points that I have mentioned, CK1, CK3, and then with the cannula, you go and fill up this hollowness that has been created because of the excision of all the 3 fat bed. And remember, being a danger zone, it is usually preferable to use cannula, but if you're really confident and have lots of experience, also you can use a needle. So this is how she looks. This is before post-blepharoplasty, and this is how she looks immediately with the filler. And this is how beautiful she looks. The hollowness, the pigmentation looks much less after the filler procedure, and she looks much young, much fresh, and the whole arrangement, the configuration of the face looks much different following the filler procedure. So mid-face lift, again, we always start with this 5 point. This is the points of the lifting, that is the CK1, CK2, CK3, which I have already mentioned. CK1 being the arch of the zygoma, CK2 being the most prominent eminence of the zygoma, CK3 in the intermediate part of the face, CK5 being the submedial or the we call the lateral medial part of the face, and CK4 being the submalar part of the face. And you can, by injecting in all these 5 points, you can bring about the change. The changes are very subtle, but if you look out here, the whole of the face gets lifted by only touching the 5 points here. As you can see, a misfit face lift, and a lady like this, who after where I had done only CK1, CK2, CK3, but what I realized, the face does not look slim. So when she came to me in the second visit, I just added the CK4, and you can see that face looks much slimmer by just addition of the CK4. And this is how she looks in the third visit after she had the supplement of CK4. This is when she came to me first. This is after the second visit, and this is after the third visit, where a introduction of some amount of filler in a specific point gives a much better slimming of the face. Nasolabial fold, this is also a tricky area. Usha has mentioned very well, but the most important indication, what we see nowadays, especially for the lips, and it really what we believe that in aesthetics, we really need to do a mid-face projection, and the lip is a very important component, which can be done with a needle or it can be done with a cannula. I prefer using a cannula because I find it's very safe. There'll be no bruise, and immediately it gives a very beautiful appearance. But sometimes with a needle, you get the bruise. And this is how you do the lips. And I usually prefer that it should be done with a cannula, but it is up to you whether you want to use a needle. But if you use a needle, be careful that you need to aspirate and wait for at least 4 to 8 seconds before you go for the procedure. And you get the beautiful changes like this. Like you can see, like this looks so aged, this lip, where you can see lots of lines, and though she is with makeup out here, you can see so many lines, and it is dried up lips, where this is just after the filler procedure, where you can see it looks so beautiful, so voluminous, and also so fresh. The jaw lines also, we have the specific point, and you can change the arrangement of the jaw. Like you can see how this jaw shape was not good, and this is after the filler procedure. And this is how you can see the change in the jowls, like this gentleman. This is immediately, you can see the jowl has been lifted up so well by just touching the jawline. So you should be very careful, and you have to give the adequate advice after the procedure, not to avoid extreme cold or heat, and not to go for any massage, and also not to go for any exercise, and better to sleep with the head and elevated. And you should know what are the complications and how to avoid the complications, because as per definition, filler is a device. It is not a medication. So because of being a device, it is prone to all technical errors where it can be the volume too much or too little, or the depth can be too superficial or too deep. But we are lucky that we have the hyaluronidase, and which can treat all the Stendhal effect or the bluish discoloration you see, or if there's too much of a product. The patient might have also the herpes infection coming back, so you should be very careful. And if you find a single facial abscess, that means the contamination has occurred through the skin. But if the patient presents with multiple abscesses, it is assumed that the contamination occurred in the syringe itself prior to the injection. So you should be very careful. You have to be very methodical, and you should make it aseptic. Sometimes even if the ladies comes to me for at least more than 4 filler injection, I prefer to do in an OR setting than as an OPD setting. And most of the patient I prefer doing in an OT setting than to take it as a very casual procedure in the OT. And the vascular complication already mentioned by Dr. Usha, it can lead to very serious vascular complication in the form of not only necrosis, as you can see here, but also it can lead to blindness. But if you have a clear understanding about the function in endosomes and also the blood supply, which I want to mention that in the face we have the 5 endosomes, and each of these have the choke anastomosis and the through anastomosis. The advantage of this choke anastomosis is that if you inject it, it undergoes spasm. So the spread of filler cannot be too much because it is being obstructed by the blood vessels which has undergone spasm. But if you inject into a through anastomotic endosomes, there is a possibility of unrestricted flow. So this unrestricted flow may lead to the spread even to the opposite side, and sometimes it might lead to a serious consequence, that is the blindness. So because of this retrograde flow from right side, it might come to the left side, and this might lead to blindness. So you should have a filler crash kit which should contain the hyaluronidase besides containing the steroids and aspirins. And also you should know, in case there is any vascular complication, it's very important you should have a clear understanding, and you should have a very good OT setup with all the emergency kit so that you can take up the situation. And the best treatment for all this complication is hyaluronidase, where initially we had a concept that if it's a small area, just go for max 20 units. And if it is large, you can go for 40 units. But now what we believe is the hyal flooding hypothesis. That means you need to flood that area with a hyaluronidase, because what happens when a filler enters into the blood vessel, there is a gradient being created here, and there's diffusion of the serum. So even if you inject a hyaluronidase, it gets deactivated. So a small amount of hyaluronidase will not occur, but if you flood it, even if they deactivate 50% of the hyaluronidase, you still have another 50% which can go inside and also prevent further complication. And it is not that hyaluronidase does not have any complication. Then this lady, she happens to be a very high profile lady in the civil services. She comes to me for the under eye filler. She was very happy. I was happy. This is just, I think, somewhere in Feb, just before the lockdown. And 6 weeks after the procedure, she comes to me mentioning that I feel a little pain here. I feel a nodule out here. So I was thinking that, okay, it can be little excess of filler, so let me dilute it. I injected hyaluronidase, but what happens? She developed reaction to the hyaluronidase, and after 48 hours, this is a picture she sends to me, and you can see this is such a bad, reaction to the hyaluronidase. So I had to give her hydrocortisone, and luckily everything got managed. But sad that the whole filler has gone off. So this is how she came first to me. This is after the filler procedure, and this is after removing the filler procedure. She goes back to the square one with all this tear trough coming up. But luckily, all the nodules have gone and the pain has gone. So with this, I conclude. Once again, I thank Chandigarh Ophthalmological Society for having me here. It is wonderful being with you all and also sharing my experiences. Thank you very much for your patient hearing.
Thank you so much, Dr. Kasturi. That was a wonderful talk as always. Could we move on to the next talk, please? Dr. Vinay Keshavamurthy to give his talk on botulinum toxin and head and neck region.
I would like to thank Dr. Usha Singh and the Chandigarh Ophthalmological Society for this opportunity. I hope the screen is visible.
Yes, it's visible.
Yeah. The previous speakers have actually made my job very easy. Dr. Usha has spoken most about the anatomy and the muscles that should be targeted with botulinum toxin, and the other speakers have also covered botulinum toxin to an extent in their talks. So botulinum toxin is mainly used for rejuvenation of the upper face, but it can also be used for the rejuvenation of the lower face and the neck. The common indication of use of botulinum toxin, at least in my practice, is for the correction of the forehead lines and the glabellar complex, but it can glabellar complex and the crow's feet, but it can also be used for correction of the bunny's smile or the nasalis, and for the correction of the gummy lines, and for the Nefertiti lift for the botox of the neck area. And it can also be used as mesobotox, where you inject diffusely over the face. It kind of gives a glow to the face because of, and dilated pores are also taken care of. So before you actually go with the injection, first know your patients well. What are their expectation and what you can deliver? And it is also important to differentiate between static wrinkles and dynamic wrinkles. Static wrinkles are present when the muscle is not being put into action, and they would not be taken care by Botox. You need to give fillers for these patients, and you can also do laser procedures for correction of static wrinkles. But the dynamic wrinkles are the one which will be taken care by botulinum toxin. You are supposed to discuss all this with your patient and take an informed consent, always under promise and over deliver. So how to reconstitute botulinum toxin? As we all know, Botox is available as a freeze-dried form, and it can be diluted with 0.9% saline. We reconstitute it with 2.5 ml of diluent. So for an 100 unit vial, if it is a 50 unit vial, we use 1.25 ml. Dr. Usha had told me long time before, but the dilution used in ophthalmological practice is a bit different. We use this dilution so that each 1 unit of insulin syringe, which is used to inject botulinum toxin, has 1 unit of Botox. So it is easy to titrate and give these injection shots when you're giving. And after reconstitution, it is ideally recommended that the Botox should be used within 24 hours, but dermatologists generally use it for 4 to 6 weeks, up to a maximum of 4 to 6 weeks after diluting the botulinum toxin. It is necessary to use all sterile precautions before you inject. If there are any infections, then don't do botulinum toxin. If there is any history of recurrent herpes, it is preferable to give acyclovir prophylaxis before doing any procedure. This is very important, especially if you are doing fillers and lasers also in association with botulinum toxin. Discuss the area which is concerning to the patient. Hold a mirror in front of the patient. So discuss the areas which are concerning them and highlight them before injecting botulinum toxin. So the injections are given using insulin syringe, which contains 30 to 32 gauge needle, and topical Embla preparation can be used to numb the face. We can also give blocks, and we can also use ice cubes or vibrators to decrease the pain. Coming to the injections per se, for the forehead lines are formed because of the contraction of the frontalis muscle. So initially, when I started my practice, we used to inject 2 units at each point, but now we are under injecting it so that it gives more of a natural look. So each of these places are injected 1 unit. So you can see that the marking points are in a zigzag manner. This is because whenever you inject the botulinum toxin, it generally diffuses to an extent of 1 centimeter around the point of injection. So to prevent overlaps, you can inject it in a zigzag manner. And it is also important that you don't inject the first 2 centimeter above the eyebrows so that the ptosis is prevented. So this is one of my patients. You can see whether when the muscle is being put into action, you can see the muscle is contracting, and these are the markings that are being injected. And this V area, you need not inject it, but because this is the site of aponeurosis where the muscle attaches. So post injection, then each of these points were injected 1 unit, and after 2 weeks when the patient comes for follow-up, there are no static wrinkles that can be seen, dynamic wrinkles that can be seen. The second most common place of injection is the glabellar complex. This is caused because of the action of the procerus and the corrugator muscle complex. And the point of injection is a line that is intersecting. A line is drawn from the medial side of the eyebrow to the medial canthus on both the side, and the place where it intersects is the point where you give botulinum toxin. The amount of toxin that is to be injected is not fixed. It actually depends on the muscle mass and the patient that is being injected. In males, we generally tends to give higher volume, and patients who have a very prominent procerus, you tend to give a higher volumes. And patients who have a very long belly, you can actually divide it and give it at 2 different points rather than giving it one single point. So in the same patient, you can, when the procerus and the corrugator muscles are put into action, you can see that the midline furrows are being seen. So he has both static wrinkles and dynamic wrinkles. These static wrinkles cannot be corrected by Botox, and you need to counsel the patient that he needs to go for fillers for correction of these wrinkles. So you can see that the corrugator muscle has a medial belly and the lateral belly, and this is the procerus. So he has a very long belly. You can either divide and inject at 2 points, or you can inject at the one single point. Generally, I tend to give 6 to 8 units at this point, and 3 or 4 units here, and 2 units at the lateral point. And at 2 weeks follow-up, you can see that the static wrinkles are present, whereas the dynamic wrinkles have decreased. Knowing the anatomy of the upper face also helps in brow lifting. One of the previous speaker actually spoke about this. The lifters, the lifters of the eyebrows are the frontalis, whereas the depressors are the procerus, corrugator supercilii, and the orbicularis oculi. So, especially in Caucasians, they tend to have this arched eyebrow laterally, whereas in Asians it is more of a flat eyebrow. So Caucasians, when you are giving botulinum toxins to Caucasians or patients with type 2 or type 3 skin phototype, you generally tend to give one shot here in the orbicularis oculi and skip the frontalis here, so that there is some amount of brow lifting that is produced laterally. And for crow's feet, this is caused due to the action of the orbicularis oculi muscle, and this is one of the important signs of aging. So the injecting point is you palpate the bony rim, and 1 centimeter lateral to the bony rim, you mark the points. There are no fixed points. You always tell the patient to put the muscle into action, and wherever you see the muscles being acted, those are the sites to be injected. So in this patient, when he smiles, you can see that these are the muscles that these are the places where the muscles are contracting, and you can see the crow's feet. So you mark the points and inject. Here, what you can see here is that there are wrinkles which are being produced even in the lower eyelid. You can inject 0.5 to 1 unit here, especially in younger individuals, to take care of these wrinkles. But in elderly, you should be careful and do a snap test, because this can in turn lead to ectropion. And again, for the intraorbital wrinkles, you can do Botox, which I have already discussed. It is important that you inject 0.5 units or 1 unit, and you can inject again in the next session when the patient comes up for follow-up at 2 weeks. But don't overdo it, because there is always a risk of ptosis. And coming to bunny lines, nasalis, for nasalis, you can inject, the nasalis can be put into action this way, and you tend to inject 2 to 3 units at these places. And perioral wrinkles, also known as smoker's wrinkles, is produced especially in patients with skin phototype 2 and 3. And these are the places that are injected. You tend to give 0.5 units at these points. Never overdo it. And you also need to know the occupation of the patient before doing perioral wrinkles. In patients who are singers, teachers, they might have slurred speech for a few days. So it is important that you discuss this aspect with the patient. And for gummy smile is because of the overaction of the upper lip elevator, especially levator labii superioris. You ask the patient to smile and put the muscle into action. You hold the belly of the muscle, and you can inject around 2 to 3 units at these places. It is important that you inject precisely at this point, because if there is lateral diffusion of this Botox here, there might be drooling of the saliva and the depression of the angle of the mouth. Marinate lines, this is because of the overaction of the depressors of the lips. So you put the muscle into action, you catch hold of the depressor anguli oris and inject it in the muscle belly. Generally 3 or 4 units are injected, and again the point of injection is important, because if you overdo it, or if the product is more diluted, it can diffuse and cause depression of the angle of the mouth. For cobblestone chin, you can either inject at one single point, or you can divide and inject in 2 different points, especially if the chin is broad. Generally 4 to 5 units are injected at this point. And Botox can also be used for treatment of masseter hypertrophy. You draw a line from the tragus to the angle of the mouth, and the anterior border of the masseter and the posterior border of the masseter are the posterior limits, and you mark 3 points like this and inject around 8 to 10 units at each point. And again, it depends on the muscle mass, then the quantity of Botox that needs to be injected. And this is the Nefertiti lift, which you can do for giving a prominent jawline, because as we all know that the prominent jawline is an indicator of youth, and this the protrusion of the fat here and loss of demarcated jawline is what we get with aging. So this is because of the downward pulling of the by the platysma muscle. So you put the platysma muscle into action and mark these points. Generally 1 to 2 units are injected at these places. It is important that you should be precise at this point, because it can, if there is diffusion of the product, it can lead to dysphonia. This is a summary of the points that needs to be marked for the botulinum toxin of the upper face. And this is post-treatment. You can see that post-treatment there is a glow to the face also. This is because of some amount of lymphedema which occurs post-botulinum toxin, because lymphatic drainage is also affected. So that gives a diffuse glow to the face. This patient also has tear trough, which was further corrected using fillers. So we need to be aware of the safe areas when you give botulinum toxin and dangerous areas when you give Botox. So the safe areas are marked in green, and the areas which you should be cautious about are marked in yellow. And never inject, especially for the upper face, never inject 2 centimeters above the eyebrows, because it can lead to ptosis. And in perioral areas, be careful about the amount of Botox which you will be injecting, because it can cause slurring of speech. And for the under eye wrinkles, just inject 0.5 to 1 unit, because especially in elderly, it can lead to ectropion. Precautions while using the botulinum toxin: patient should be instructed to repeatedly put the muscle into action, especially in the first 2 days, so that the uptake is better. And one should not bend down or exert more immediately post botulinum toxin injections, so that there is no diffusion of the product. The injections need to be repeated generally between 4 to 6 months interval, and with repeated injection, generally the duration of effect tends to shorten, and you need to inject it more frequently. Avoid the at-risk areas. I think this is it. Thank you. If there are any comments or doubts, you can mail me on this email. Thank you.
Thank you, Dr. Vinay. Thank you so much. That was a wonderful talk. I think we are really running out of time, so we'll just move on to the next speaker. It's my pleasure to invite Dr. Feroz to give her talk on case files in blepharoplasty. And maybe if we have time at the end of that, we are already 7 minutes over, we can go for some questions. Dr. Feroz, please.
Thank you, everyone. I'm going to slide. At the outset, good evening once again to everyone. Thank you, Chandigarh Ophthalmic Society, for having me here. Is my slide visible?
Yes.
Yeah,
Yes.
The president, Dr. Usha, who has always inspired me, be it in oculoplasty or ocular oncology, and Dr. Chintan for this kind invitation. I'm elated, and indeed is an honor to be here with the doyens of facial oculoplastic surgery in India, Dr. Kasturi and Dr. Debraj Shome, who has contributed tremendously in the field of facial oculoplastic surgery, be it a newer technique, be it the precision in the technique, and even patents. So it's not an easy job. I have been given a very tough job today by Dr. Usha Singh. And in the next 8 minutes, I'm going to take you through a few case files in blepharoplasty. I have no financial disclosures or interest. Just going through this particular literature that has been published from the American Society of Ophthalmic, Plastic and Reconstructive Surgery before I go on to the case scenarios. They reported an average of 196 upper eyelid and around 50 lower eyelid blepharoplasties being done by the members of ASOPRS. But we don't see such numbers in India, despite the fact that we see cases which is indicated for blepharoplasties in our regular OPDs, which sometimes gets overlooked. Although currently the trend is increasing, it's a positive news for the practices. Blepharoplasty, although it has various indications which has already been discussed by Dr. Kasturi and Dr. Debraj Shome, we have functional, we have cosmetic, and 75 to 80% of my blepharoplasty cases fall under the functional category, and around 20 to 25% belong to the cosmetic category. So before going on to the case scenarios, I just wanted to highlight what are my check marks before I go ahead with the surgeries. Thorough counseling is very, very important to discuss about the expectation of the surgeon and deliver. Definitely previous pictures, a series of it, so that I can, express and tell them what can be delivered at the end. Meticulous pre-op evaluation, marking every millimeters, the angles, the bits are very important, and seated preoperatively done in a supine position. So the most important thing that I follow in my blepharoplasty is a conservative approach in order to have an absolute, near normal restoration of the face. So this is what I follow in my practice. So going on to the first case of today, it's a very simple case that everyone, even a general ophthalmologist would be coming across in their clinic. So this was a male patient in his late 40s who came with a complaint of bulge in the right eye and the yellow lesion in his left eye. We all know that it's a small xanthelasma sitting in the left upper lid, and then he has a medial upper lid fat bulge. The patient was counseled for bilateral blepharoplasty, where the xanthelasma was also excised along with it, and this is how he looks before and after. So this is a simple case of a xanthelasma where a blepharoplasty was combined in both the eyes to address the complaints that he had. Now, this was a patient in her early 30s. So she had undergone ptosis surgery elsewhere, and then she came with a complaint that her eyes are, as you can see here, the left eye, which has been operated earlier, there is increase in the pretarsal show and there is multiple lid crease. So I'm going to take this question to the panelist over here, to Dr. Debraj Shome and Dr. Kasturi, for an interaction. Basically, what would you do in this situation where a young patient has come with this complaint where she feels that her eyes are asymmetric? Dr. Debraj and Dr. Kasturi?
Yeah, sorry. The asymmetry between the two eyes, the left eye showing is it the asymmetry you're mentioning?
Multiple lid crease and increase in the pretarsal show.
Is the
patient's complaint is asymmetric, not same anymore. She had undergone a ptosis surgery, which I understand is a posterior approach in the left eye.
Mm-hmm. She still has some amount of this. It is asymmetry between the two eyes. On the left side, you can see that is the left ear. On the left side, you can still see that there is a little bit of hooding, and on the right side, you can see some amount of the crease, right? Multiple crease.
Left side, yes, multiple crease after the surgery, yes. And
Yeah.
that's the concern.
So that is what I think needs to be corrected. I think it will be better if you correct the creases, the one with the creases with the blepharoplasty.
Okay. All right. So ma'am, you would like to address the left eye in this particular case, make a new lid crease.
Yes.
All right. Dr. Raman, anything else that you would like to do, or would you go for the same approach in this particular case?
Well, first of all, I would have loved to, I don't know how the patient looked in the first go or pre-operatively.
Okay.
Otherwise, if there was an asymmetry earlier, I would have loved to go through the skin crease and the first go so that my symmetrization or the pre-tarsal show would have been better and matching the crease. But in this scenario, probably either the way she says, it has to be counseled with the patient, the left eye forming a crease and making it as a smaller pre-tarsal show, or even we can go ahead with the right eye a mini bleph and can reduce the fold which is overhanging over the crease. Once the fold which is overhanging the crease is removed, I guess the pre-tarsal show of the right eye will also increase and probably would match the left eye. So these are the two options with me.
Feroz, I'm sorry I disappeared. I just didn't have a clue that I would be.
Just keeping it interactive and
You were caught right-handed. That's the
No, my apologies. I just didn't have a clue that I'd be on the spot. I think, one thing that I would say, Feroz, is first thing is to go ahead and make sure that we know the earlier pictures. I think I agree with Raman Bhai's comments completely. We would want to see the earlier pictures. The second thing I have a real problem with is to see the eyes zoomed up in this manner. Because seeing the eyes zoomed up in this manner gives you no clue about the brow. At this moment in time, with the picture which is being shared, the right brow actually appears to be flatter than the left brow. And it also, I don't know how the...
have a browtosis, Dr. Debraj.
No, that might be true. That might be true. Without having a browtosis, there might be some asymmetry between the brows. And the important thing to remember is that whenever we have an asymmetry in the brows, typically it will lead to some asymmetry in the lid folds as well. None of these parts exist in isolation from each other. They are all a continuum. Also, looking at the rest of the face would be very, very important, because if I look at the curvature of the left eyelid and the curvature of the right eyelid, they are very different. Actually, the lid height may be the same, but the curvature, if you look at the right side, is a little bit squarish, as opposed to the left side, which is a little bit more contoured. As our job as aesthetic surgeons is not to see straight lines, it's also to see contours. So I would like...
Can I go ahead with the result?
Of course.
All right, yeah. So Dr. Raman, I did exactly what you thought. So what I did in this particular case was I did a bilateral blepharoplasty. So I was able to counsel her and convince her that she in fact had a little bit of blepharochalasis in the right eye. And of course, with this multiple lid crease and an increased pretarsal show. So this was how this case was managed with a bilateral blepharoplasty, a minimal blepharoplasty in this particular case. So yeah,
Wonderful
so each surgeon has a different take on different cases. And ultimately, if the patient is happy with the results, the surgeon is also happy. So this was a case of blepharoplasty bilateral done for a unilateral issue in a patient with symmetrization of the pretarsal show. Going on to the next case, this is quite important. My colleagues, cataract surgeons and other departments. So this was a patient who has undergone a post-cataract surgery by an excellent cataract surgeon with 6x6 vision with an imported IOL sitting inside the eye. The patient is still not happy after the cataract surgery. And it's very, very evident in this picture. As you can see here in the right eye, there is, the lateral hooding is there. There is severe dermatochalasis. There is some amount of browtosis over there. And left eye, significantly, he has ptosis. So he says that despite having a cataract surgery, my vision is not completely, recovered. So we see these patients very, very regularly in a regular OPDs where, the cataract surgery is taken care, the retinal detachment surgery is taken care, but minute issues like, the lateral hooding, the extensive dermatochalasis these patients have, and the ptosis that these patients have is often missed. So these are the ideal candidates. despite the age that we have, where a vision can be improved, and as well as the cosmesis. So this patient underwent a ptosis repair surgery in both eyes, where the ptosis was more severe in the left eye, along with the blepharoplasty in improving the vision as well as cosmesis. So this is more of a functional issue that the patient had. Yet another patient, similarly, his vision was compromised despite bilateral cataract surgery, as you can see here, the PCIOL in situ. So he has a significant amount of brow ptosis. He has severe hooding, lateral hooding of the upper lid and dermatochalasis, with even the subbrow fat thickening over here. So this patient also underwent a blepharoplasty with additional brow pexy to, in order to explain that he had after the cataract surgery. So we all need to look inside our regular OPDs, where, most of the things are taken care, but still these patients have issues despite having good vision in their age. Hello?
In the previous case, yeah, Feroz,
Yeah.
just interrupting you because it was an interesting case. In the
Okay.
previous case of the gentleman with the brow pexy you did, if
Yeah.
it was a good browplasty would have been done, I guess bleph probably would not have been needed, because it was more of a browptosis in this case.
Yes,
And
I agree. So yeah, he didn't require a very extensive blepharoplasty, but blepharoplasty, a minimal blepharoplasty, was combined with bropexy in this case.
Okay, probably we can debate on this a bit, or not debate, rather, I would like to take Dr. Kasturi's opinion. Would you first go for a browplasty and then would like to decide on a bleph, or you would like to take it in a single go?
Actually, we need to go for a thorough assessment of how much amount of brow ptosis she has. So based on the grading of the brow ptosis, I think first we should have addressed the brow. And after that, how do we address it? Once you lift it and you see that how much, if it is less than 2 millimeter, we say a less amount of mild brow ptosis. But if it is more than 2 millimeter ptosis, we say that it is a more severe brow ptosis. So if it is a more severe brow ptosis, definitely you have to do a blepharoplasty along with the brow ptosis. But if it is mild, less than 2 millimeter brow ptosis, then you can just manage with a browplasty. But definitely an external approach would be better for him. What do you say? Raman?
Yeah, I would have probably, of course, initial assessment is important. Probably I would have done a browplasty, then later on a bleph, rather than going it in the first single stage, even if it was a severe case, because to my mind, seeing the picture, once we would have done a browplasty, it would have addressed quite a bit of visual concerns at least. But yes, for a better cosmesis, and as we are dealing with aesthetic classes, probably browplasty would not have been an ultimate answer to the aesthetic sense of this patient, and bleph would have been needed. Yes, to save the time and to give a good result in the one go. Feroz did nicely both the things in one go. Probably I would have done a serial this thing, and I also see that Feroz also removed this mole nicely without an extra charge.
Yes. All right, yeah.
And many times what happens when this patient, they undergo cataract surgery because of this lateral hooding that they're having, it affects the contrast. That is a very serious complication, complaints they have. And not only the contrast, it also affects the high order aberration, which we never assess it. But if you really assess the high order aberration, you see that this is really very much compromised. So a little opening laterally, if you can do a little bit of extended blepharoplasty along with a browplasty, it also improves the other functional complaints that they have in the form of the contrast sensitivity and the high order aberrations. Like in these situations, when I get a lateral hooding, I always pre-operatively also check for the contrast sensitivity, the lateral field of vision, and the HOA.
Dr. Kasturi, would you like to get a CT done here to see for lacrimal gland prolapse?
Yeah, not exactly, because he's such an elderly person and it is very obvious. He has got very thick brow tissue. So it doesn't look like a, but also I usually do the prone test and I see if it is more than what is before the prone test, then definitely I think I'd have loved doing a CT. But prone test is really helps you to know whether the patient has got a lacrimal gland prolapse or not. And had this person been less than 40 or 35 years, I would have advised a CT scan. But already you can see all the aging changes in this person.
Okay.
Devraj, what is your preferred route of doing a blepharoplasty or a blepharoplasty?
If in a patient like this, I would go ahead and do an internal blepharoplasty simply because it would be a lid crease opening in any case. But I agree with everyone here that he's got very heavy brows. And with an internal blepharoplasty in my hands, I don't think the results would have lasted more than 5 years because it's very heavy brow tissue. So it's a difficult one, really. So given the fact that he's got such heavy brows, and if he came in for a real correction, maybe I would just go ahead and use a direct brow lift also, which if you can hide it beneath the, slant of the hair follicles, you may be able to get away without a visible scar in this case.
I can tell you a very small tips to it. You just make approximately 1.5 centimeter incision, and what you do, you go vertically up and expose the frontalis muscle and vertically down and the orbicularis, and either side you placate 1 centimeter 1 centimeter, and then you can also excise the excess tissue and then suture it. It gives a beautiful correction. I do in many. There's a very simple blepharoplasty by doing, placating on either side.
Ma'am, do you debulk the subbrow soft tissue in such heavy brows?
Pardon?
Do you debulk the subbrow soft tissue in such heavy brows?
If I do externally, yes, sometimes I remove, but internally when I do, I don't remove. I don't even remove the roof also internally when I do.
Oh, okay.
Dr. Kasturi, what I heard was when you give a central incision and then you do the central 1/3 maybe, the way you said, and you placate the frontalis as well as the orbicularis, that would give a good in the central
and you fix it to the periosteum in the orbital rim. Fix it.
Arcus marginalis. That's where the fixation would be, Dr. Raman. Right, ma'am?
Pardon? Yeah.
The arcus marginalis.
You expose the frontalis up and the orbicularis. You pull and you see. You will see the nice pull of the orbicularis. So what I do, I placate the orbicularis and also I placate the frontalis. Sometimes you can excise it also after tightening the suture. If you think that it is already very heavy, that part of the frontalis and the orbicularis, you can excise it. But the final fixation, you do it with the periosteum where you want the eyebrow to be, there. So this gives a very full correction.
What I wanted to ask was whether the lateral part would be also corrected in this procedure, or only the central and the medial part would be? Because I guess the lateral things don't get addressed if we just go directly onto the central.
We do for the lateral part only. I give the incision between the medial 2/3 and the lateral 1/3.
Okay, right.
And it should be a matrix. It should be a vertical matrix suture with a fixation to the periosteum.
All right.
Sorry for the interruption, Feroz, but I thought that was what.
That is exactly why I have kept it so interactive, because
of the country here in this. So I wanted to just discuss this point.
Yeah, absolutely. So we go on to the next case of the day. So this young lady in her early 30s came with complaints of I look tired, and from the picture it's very, very evident here that she has these lower eyelid bags that she's not happy about in her early 30s, where it gives her a tired look. So whenever we have a lower eyelid bag, which has again been discussed thoroughly by our previous speakers, there are many things that we have to look into: the cheek descent, the hollow tear trough, the pseudo herniation, skin laxity, whether there is any sun damage. It has to be differentiated from festoons and other causes of lower lid bags. And so in her case, it was definitely a bulging of the fat. And we had a discussion where Dr. Devraj had put an excellent question, where a transconjunctival bleph should be combined with fat draping or not. So this is just to show the serial picture, just to show how there is some amount of fat atrophy that is happening in the facial plane as the age progresses. So especially in a young patient, so I don't do fat draping in all cases, but if it's a young patient in the presence of a negative vector, I would prefer more of a restoration than an excision of the fat. So this patient again, a transconjunctival blepharoplasty was done with fat draping. in the lower eyelid, and this is after 2 days of the surgery, and this is after 3 weeks post lower lid blepharoplasty with a transconjunctival approach with fat draping. So listen to the fillers. It could be a fat fillers or other fillers over here. So both has been discussed. The options of fat fillers as well as surgical blepharoplasty has been discussed with this patient. But when it was explained that she might have to get repeated fillers, she opted for a transconjunctival blepharoplasty. So again, the question goes to the panelist over here, to Dr. Kasturi, Dr. Debraj over here, whether you would think that the fillers would have benefited her or surgical excision would have benefited her.
Definitely, she appears quite young.
Very young. She's 32-year-old, ma'am.
Yeah, we should have given a trial of fillers.
Fillers, yeah.
That is what that would have been my first choice. Like only to camouflage it, you could have given a thicker filler along the valleys, and in case, and it is, if you use a Juvederm product, definitely a little undercorrection. But sometimes I use Voluma also, and I feel that the hydration of Voluma is less. It's 8 o'clock. In fact, for the last many months, I've been using Voluma with the cannula. So whatever filler you use, I feel that filler would have been my first choice. And later I'd have thought, because she's quite young.
Yes, ma'am. Have you ever came up with a clinical scenario where you actually your first option is filler, but then when you tell the patient that she or he might require repeated fillers, that they actually fall back on your first option, and they just want to go ahead with the surgeries?
Usually, when I plan for surgery, I insist that they should do at a later stage, because one of the very important step in the lower lid blepharoplasty is the internal growth vaccine. And these young people, they already have a very tight lower lid. So even if I do a surgery, she will definitely need a repetition after some years. So that's why I give filler as a first choice, and then only the blepharoplasty in the little elderly age group. But yes, initially in my practice, I also used to do blepharoplasty in young people also, which I'm learning from my own mistakes. So for young, definitely first choice is filler. And if it is young and still they want something permanent, because repeated filler becomes a much costlier, that case, that you have done.
Yeah, so that was the concern that the patient had, that she was not willing to go ahead with the repeated fillers. One is like, every alternate, year she has to get it filled, and of course the financial issue. So that's why transconjunctival blepharoplasty with draping was done. So this was an Asian male who came with complaints of puffy eyes, and he definitely wanted a cosmetic correction. He has undergone ptosis in his left eye elsewhere. As you can see here, he has a recurrent ptosis in the left eye as well, and there is lots of excessive skin dermatochalasis. There is fat bulging, there is lower lid bag in both the eyes, and he said that he want to look a little bit more younger and rejuvenated. So what was done for this patient was a quad blepharoplasty and a SMAS lift, which ultimately gave him a good facial rejuvenation. Any comments from the panel on this particular case?
Beautiful results.
Okay, thank you, ma'am. So, ma'am, you always combine SMAS lift, or do you have any particular indication of SMAS lift with quad blephs?
Yes, SMAS, I do it when I need to do an external approach.
Okay. Yeah, this was an external approach. As you can see, there is a very minimal, scar in the ciliary margin over there.
And if I feel that there is some amount of the SOOF, there's doses of the SOOF. So those are I usually advise SMAS lift. And along with it, I take some bite of the SOOF. But definitely only with the external approach, I do a blepharoplasty, and I cut the lateral fat bed. I only redrape the medial and the central fat bed, and I do a lateral cantoplasty and a SMAS ocular sleeve.
Okay, all right, yeah. So this was a combination. Yes, ma'am.
as a maximum down, you should go. Like you should go at least to this LR region when you this mask from the rest of the other tissues.
And then really lift it up.
Lift it up and suture it up as possible in the periosteal, temporal region.
Okay, ma'am, what is the choice of your suture?
I usually use polyester nowadays. Most of the suture, anything where I need to touch the periosteum, even for the LPS. Initially, one of them I used to use the Prolene, but I've seen that after many years also, the Prolene cuts through. So when I deal with the periosteum, I usually prefer using a polyester nowadays.
Okay, all right. Any comments from the rest of the speakers and the panelists, Dr. Raman, Dr. Devraj?
We do a lateral tarsal strip. With the Prolene, it leads to recurrence. After many years, you'll see recurrence when you do in a much like a middle-aged person. You do it, then after a few years, you might see some of the recurrence. So that made me stop using Prolene or any of this monofilament for the periosteum.
All right. Thank you, ma'am. Any other comments from Dr. Devraj and Dr. Raman, the panelist?
Feroz, I think Devraj has already left. He mentioned that he had to go. Regarding my comments, I think most of the important comments have been taken care of by Dr. Kasturi. Though in this case, seeing the result, probably I would have done a bit more of blepharoplasty as some overhanging skin. So my approach would be slightly more aggressive on the upper lid. Yeah, the lower lids have been nicely and very nicely done. And of course, the SMAS lift has been wonderful. So probably on the upper lid, I would have done a bit more.
Okay. Thank you, Dr. Raman. Thank you for that output. So, well, I do the blepharoplasty also comes handy in situations in my ocular oncology practice as well. This is a case which had, a large seborrheic keratosis sitting, as you can see here in the external picture in the left upper lid. So after the excision, there was a requirement of a skin graft. And so a blepharoplasty in the contralateral right eye was done, and the skin from the right eye was grafted to the left upper lid in this for this extensive seborrhokeratosis. So yes, it does come handy in ocular oncology practice as well. And this patient was referred for a puffy left eye, as you can see here. It was earlier diagnosed as angioedema, but when you look closely, the diagnosis is staring at you. It's a case of a bilateral xanthogranuloma in a young patient, and it is obviously more in the left side than in the right side, but there is a yellow hue which is progressing in the right eye as well. So blepharoplasty, there was tumor debulking was done, which was combined with LPS resection, since the xanthogranuloma tumor was infiltrating the levator palpebrae superioris. The ptosis was corrected in the left eye, and blepharoplasty was combined along with this. So it does come handy in as a part of an eyelid reconstruction in eyelid tumors also. So, well, to conclude, I definitely believe in aging gracefully. And from this picture of my beautiful mother, I definitely know where I will be in the next 40 years. And as a surgeon, there are many things that I would, would want to conclude. It's very important to identify the indications, be it functional or cosmetic, and a meticulous preoperative evaluation, which all the speakers and the panelists have put across in this particular webinar over here. And an explicit counseling is very, very important. And in my approach to blepharoplasty, I always am conservative. So thank you very much for your patient listening here.
Beautiful presentation, Feroz. I'm so happy seeing your results and your interest in blepharoplasty. I feel that as a senior, I think at least I can make you all understand. And I think indirectly we learn from each other. So very nice presentation. And I should really thank Usha for this great webinar.
Yeah, thank you, Dr. Feroz, for this excellent discussion on the cases. And Dr. Kasturi, your comments are invaluable, and so is Dr. Raman's. And thank you, Dr. Vinay, for your excellent talk on botulinum toxin. And I'm really happy and I'm grateful that you people have agreed to participate and present your cases over here. And I'm sure we can look forward to more such interactions. I thank you all very much from all the members of COS. And I would like Dr. Chintan to come on board now, if she's around. Dr.
Hi,
Chintan.
ma'am. I'm very much around. I don't know why my video is not showing up. And despite being a non-oculoplasty and a non-aesthetic surgeon, I think I've enjoyed this webinar much more than I've enjoyed some of the others. There were so many nuances to it. Of course, I didn't understand the scientific part.
Chintan, can we have a pic for all of us?
Yes, ma'am, please. I don't know why my video is not showing up. Please, let's go ahead with the...
Vinay, if you're around, please put on your video. Let's take a pic of...
Oh, okay.
Dr. Chintan, you yourself are not visible.
I know. I don't know. There's some technical problem. As long as I'm heard, that's fine.
Photoshop it later.
Yeah, we'll do that later. But thank you all so much. And I think this has been one of the best webinars of our society.
Thank you, Dr. Raman and Dr. Manpreet, for being with us today evening. And
ma'am, we should thank you for bringing this to a platform
and augmenting our COS meeting.
And also thanks to AIC Healthcare, Rohit and Sandeep have really worked hard, I think, and they've kind of coordinated very well with everybody.
They still are on the job and they are just sitting next door and they're monitoring everything. And so I think they've worked really hard and they've made this go seamlessly, and it has gone on very well. Thank you all so much. Can you take a pic, Dr. Chintan? Dr. Chintan, can we take a pic, please?
Yes, ma'am, please. I am not visible. You please go ahead. I don't know why I'm not visible.
I took a pic, ma'am. I took a pic of the screen, but only 5 of us are visible. So I'll put it in the group.
Yeah.
I think initially also somebody took the pic, but it just
I've taken a few. I'll put them. I've taken a few as well.
So I guess I hope the pic will be fine. And it was nice to see you, Kasturi and Feroz. I couldn't meet you last year. So it was a long due meeting, and I really thank Dr. Usha. At least virtually we could meet.
Yeah, I know. At least we should be meeting.
This is a good part of the COVID pandemic.
And Feroz, it's so nice to have you here. You're very active on the oncology group. We all know that.
Yes.
And I suppose I suppose this COVID situation is going to be like this, and we'll have to make do with these webinars till everything is sorted out.
Yes.
Thank you all, and I wish you all the best. Dr. Chintan?
Yes, ma'am, I'm there. I'm just not seen.
Yes, would you like to say something now?
I just want to thank everybody again. It was wonderful. And we look forward to having some other webinars with all of you again in the near future.
Kasturi, I just want to say I've learned a lot by hearing you. You always extend yourself much more than expected by all of us each and every time. So this is really amazing. She is really amazing, and I'm really amazed at the presentation, the way she extends herself. I think we all should be learning all these things. And we have learned a lot from Dr. Kasturi, Dr. Devraj, Dr. Vinay. And I really wanted to wanted to hear Dr. Vinay's talk. Very nice talk. And I'm sure we can interact more, Dr. Vinay.
Surely, ma'am.
Yeah.
Thank you, everyone.
Bye-bye.
Bye-bye.
Raman missed so much in the last OPI.
Pardon?
You missed Raman.
Actually, I missed.
You did, yes.
Kasturi, I already knew that you'll be the most wondrous show ever on this oculoplasty platform. And I am so sorry that I couldn't be there as a part of that. And I really missed. And they keep bugging me with the pictures, and they keep, teasing me with those wonderful pictures. They had the gala time there in this meeting of yours. And they keep teasing me that you missed it. See that Feroz and all the team, I know these people that keep on teasing me. So next time again, you'll have to call me up again. Do host a meeting very soon.
Meeting. We'll do that. Sure. Next time in Shillong, we'll have it.
Yes, that's the way. Bye-bye then. Bye.
Bye-bye, everyone. Thank you so much again, once again.